Hello, chairpersons. We are live now. You can begin now.
Good morning, everyone. We can begin the e-paper presentation session. Can we have the list of the people who are presenting, because we don't have the list and the order? Is anybody there from the organizing committee? We don't have the list of the paper presentation. हेलो हाँ जी क्या चीज? हाँ हाँ हाँ, but how many papers are there? 13. और कोई लिस्ट है, कोई पैरामीटर्स हैं on which we have to judge them? But we don't have any further information from the organizer now on what parameters we have to judge, what marks we have to give. बता दीजिए। ओके।
My title is a comparative study to evaluate the post-operative analgesic efficacy of erector spinae plain block versus thoracic paravertebral block in patients following modified radical mastectomy. Co-authors are Dr. Nitin Hayaran and Dr. S.K. Sinha. Breast cancer is the most common female cancer worldwide. The most common breast surgery is modified radical mastectomy, which is associated with significant acute and chronic pain. Thoracic paravertebral block is the gold standard for multimodal analgesia, but however associated with some minor and major complications. Recently, erector spinae plain block was proposed by Ferrara et al. In 2016. There have been a limited literature on comparison of efficacy of postoperative analgesia between both the blocks, and no studies have been done so far on interpolation with the placement of continuous post-operative infusion catheter. Cooperative study was done on 60 adult female patients posted for elective MRM under GA. Clearance was from Institutional Ethical Committee. Aim was to compare post-operative analgesia in patients who received both the blocks at 24 hours. All patients were explained NRS Committee. Aim was to compare postoperative analgesia in patients who received both the blocks at 24 hours. All patients were explained NRS preoperatively. Patients were randomized and allocated to either group E or group B. GA was induced as per standard protocol following placement of either blocks with 20 ml of 0.5% bupivacaine, and a catheter was inserted under ultrasound guidance. At the end of surgery, a continuous infusion pump of 0.125% bupivacaine at the rate of 8 ml per hour was started and continued for 24 hours. During immediate post-operative period, patients were asked whether they have complaints of pain or not. If yes, the site of pain at which the quadrant was asked, and the pain was quantified by NRS as 0, 4, 8, 12, and 24 hours. Injection tramadol was given. If NRS was more than or equal to 4 and total number of doses was calculated, local site was inspected for signs of complications, and catheter was removed at the end of 24 hours post-operatively. All data were entered and performed for each patient. Was compiled and tabulated, and a p-value of less than 0.05 was assumed statistically significant. And the following table and figure shows the distribution of study group based on NRS score at various intervals. The mean NRS score was comparable between both the groups ESPB and TPVB at throughout the 24 hours post-operative intervals. At the 8 and 12-hour interval, the mean NRS score was significantly lower than in SPB. The mean NRS score was significantly lower compared to TPV groups, but however, they were clinically comparable. And coming to the figure, at 0 interval, the mean NRS score was minimum and increases and reaches at peak at 4 hours and then started to decline till the end of 24 hours. And figure 2 shows the distribution of study group based on the site of pain. The difference in the site of pain according to quadrants of breast is statistically insignificant. And figure 3 shows the distribution of study groups based on mean of consumption of analgesic tramadol, and the difference in the consumption of analgesic tramadol were comparable in both the groups, and no complications were reported in both the groups. And coming to conclusions, both ESPB and TPVB are effective in managing acute postoperative pain after MRM. They are equally efficacious, and site of breakthrough pain in both the group shows that ESPB may be more effective in managing axillary pain because of extensive spread of LA. Both are equally effective in reducing opioid consumption. Continuous catheter techniques further reduce opioid consumption, and as ESPB is less invasive than TPVB, it may be considered as the analgesic method of choice after MRM. These are my references.
So how did you calculate your sample size? How many patients were there in each group? Do we have the presenter online right now?
Is there anybody there?
Hello? When the presenter is not there, so we can move next slide.
Yes, okay. If the presenter is not online right now, we can go on to the next presentation. The slides were also not moving in the first presentation. Is it a pre-recorded?
Yes, ma'am.
Okay, thank you.
No, because of some technical issue, the slides are not there.
Anesthesia care for patients in need of not just tweaking, but radical change at the times of pandemic. I did this clinical series during the first wave and continued during the second wave. During the first wave, me and my fellow doctors established an NGO to help the COVID-19 patients, out of which I received 30 COVID-19 parturients where I used a modified anesthetic management for their delivery. So the management of these emergencies involved twofold management of these obstetric patients. That is, caring of this obstetric patient, they may be asymptomatic.
You got in? You sent that link to me also. I am struggling also when you called. You pass it on to me also. You pass it on to me also.
Hello, myself Dr. Vibha Sakrin. I'm senior resident in Raipur Institute of Medical Science. My title for presentation is Comparative Study of Buprenorphine, Dexmedetomidine, and Clonidine as an Adjuvant in Subarachnoid Block for Lower Limb Orthopedic Surgeries. So to start with, spinal anesthesia is safe and reliable method of anesthesia for abdominal and lower limb surgeries, and in order to improve the quality of blockade, various adjuvants are added. So this study was designed to see the efficacy of dexmedetomidine, clonidine, and buprenorphine given in hyperbaric bupivacaine for lower limb orthopedic surgery. Buprenorphine is 25 times more potent than morphine and is a mu receptor partial agonist, while clonidine is an alpha-2 receptor agonist and dexmedetomidine is selective alpha-2 receptor agonist. Now, this is my master study from which sample size calculation was done. The aim of the study was to compare the efficacy in terms of onset of sensory and motor blockade, height of blockade, and duration of sensory and motor blockade. The objectives of study were primary, including onset and duration of analgesia and motor blockade. Secondary objectives included motor, hemodynamic variation, and intraoperative and postoperative period. postoperative analgesia, complications including nausea, vomiting, bradycardia, sedation, hypotension. The study was conducted in Jagjeevan Ram Railway Hospital for 1 year of duration. Adult patients of 20 to 65 years of age under ASA 1 and 2 were selected for the study. It was a prospective randomized single-blind comparative study. Total 90 patients were selected and divided into 3 groups of 30 each. Each patient received 15 mg of 0.5% hyperbaric bupivacaine, with Group B receiving 90 mg of buprenorphine, Group C receiving 30 mg of clonidine, and Group D receiving 5 mg of dexmedetomidine. Onset and duration of sensory block, highest level of sensory block, time to reach highest dermatomal level, motor block onset, time to complete motor block were recorded. Postoperatively, motor block recovery, sensory block regulation, and pain score using visual analog scale was assessed. Statistical analysis was done using SPSS software version 21. Out of 90 cases, 75% cases were of total knee replacement, and in postoperative period, it was observed that the maximum duration of sensory block, duration of analgesia, and duration of motor block was seen in dexmedetomidine group, followed by clonidine and buprenorphine. Breast pain control was seen in cases of dexmedetomidine group in first postoperative period, and highest VAS score was reported in cases of buprenorphine. Complication cases were lowest in dexmedetomidine group as compared to clonidine and buprenorphine. Clonidine showed significant hypotension as the maximum side effect for its patients, and buprenorphine main complication was sedation. For discussion part, breast pain control was observed in dexmedetomidine group, which was comparable with a study comparing dexmedetomidine, clonidine, and fentanyl, showing that dexmedetomidine was having highest duration or maximum duration of analgesia. Similarly, a study done by Gupta et al. Showed that on comparing dexmedetomidine with buprenorphine, it was duration of analgesia was higher for dexmedetomidine group. For complication rate, significant hypotension was seen in cases of clonidine and sedation for buprenorphine group, which was comparable with a study done by Ravindran et al. Showing that side effect of evaluation was sedation was the most common seen in buprenorphine study group. A study comparing buprenorphine, clonidine, and fentanyl as adjuvant showed that highest level of hypotension was observed in cases of clonidine. So to conclude, good analgesia is achieved by clonidine, but its use is limited by incidence of hypotension and bradycardia. Use of intrathecal dexmedetomidine as an adjuvant to bupivacaine is good alternative to clonidine and buprenorphine, but its prolonged duration of motor blockade can be undesirable for short-term surgical procedures. These are my references. Thank you.
So, Dr. Vibha, are you there?
Yes, ma'am.
So, Dr. Vibha, how did you decide about the doses to be given for dexmedetomidine, clonidine, and buprenorphine? The doses mentioned 30 mics, 90 micrograms.
So, initially, I have compared my study with my master article. So, in that, most of the doses were compared. And for buprenorphine, basically, I had started from a maximum dose to lower dose. So, accordingly, by selecting 1 or 2, 3 articles and comparing them, so I had selected my dose.
Okay, and the second question is you had 2 primary outcomes. One was onset of analgesia and one was onset of motor blockade. Since both will happen at varied times, so how did you calculate the sample size for your study? Like you'll take 90 patients and divide 30 each.
According to the sample size formula, which was given by my statistician, so initially N value was coming to be 15. But as per availability of patients in my institute, I had taken 30 each, and for according to standard deviation curve, so I had taken 30 each and 90 for the total case study.
Yeah, the statistician will give us the formula when we tell them what is the primary outcome to be compared. So which primary outcome you chose to calculate the sample size? Because you have 2 primary outcomes, so this becomes a complicated calculation.
It's analgesia, I told you.
Onset of analgesia. And what difference you expected in 3 groups? How much % difference you expected to calculate the sample size?
Sorry, I don't know about that.
Okay. Dr. Rahil, you have something?
Yes, Dr. Vibha, I wanted to ask you the standard dosage that you gave, the total volume 3.5 ml, that was standard for all the patients, irrespective of the patient profile that you had? Because I feel that 3.5
All
ml,
patients.
3.5 ml is quite a large amount of, let me finish my 3.5 ml is quite a large volume to be given to the patients, especially you said that majority of your patients were TKR, they're quite old patients, and 3.5 ml, I believe the hypertension that followed, how can you attribute to the adjuvant and not to the dosage that you are giving? That's quite a large volume, I suppose.
Most of the patients were of ASA1 and ASA2, so accordingly patients were selected. So
no, that I understand, but 3.5 ml is quite a large volume, I believe.
Ma'am, it was a standard dose in our institute only, so I followed that protocol.
And you did not put any epidural in any of the patients, only spinal?
I had given epidural for postoperative analgesia. So intraop, I had, yes,
postoperative. And epidural, you gave 3.5 ml drug. I believe that it is a very large volume of drug.
So epidural was just used for analgesia, postoperative analgesia, nothing else.
Okay.
Okay.
Thank you.
Thank you, ma'am.
Warm regards to everyone. My topic for this e-paper is the effect of normal saline and plasma light on the acid-base status in patients undergoing head and neck surgery with pre-flap reconstruction. Anesthetic management of head and neck pre-flap reconstruction is challenging. Proper fluid management is essential, but the debate is over the correct perioperative fluid therapy. Multiple studies has been done, but in critically ill patients and hemorrhagic patients, but there is a paucity of data to validate use of any one crystalloid over the other in these prolonged surgeries. Thus, we have conducted this study with the aim to compare the plasma light and normal saline in terms of acid-base balance and electrolytes in the perioperative period in the head and neck pre-flap reconstruction surgeries. Primary objective being to compare the effect of plasma light and normal saline administered during head and neck pre-flap surgeries on metabolic profile during and after surgery, and secondary objective being to compare the outcomes, that is blood loss, urine output, graft viability, length of ICU stay, hospital stay. Coming to the methodology, this is a prospective single-centered observational cohort study. Inclusion criteria and exclusion criteria are mentioned here. Total 82 patients were undergoing head and neck pre-flap surgeries were taken into the surgery. 7 patients were excluded due to the exclusion criteria. Monitoring, induction, and maintenance of all patients were done in a protocolized manner. Intraoperative fluid therapy was given as per the consultant anesthesiologist in charge, who was not a part of the study. ABG samples were monitored at T1 to T7 time points. Intrafluid given was assessed by the primary investigator at the end of the surgery. Depending upon the amount of fluid used intraoperatively, if it was more than 75% of plasma light, then they were grouped into group A. And if it was more than 75% of fluid used was normal saline, it was group B. A total of 4 patients were excluded because equal amount of plasma light and normal saline was used intraoperatively. Vitals, arterial blood gas analysis, urine output, viscosity of the graft were assessed and compared till postoperative day 3. Data analysis was done by SPSS software. Patient characteristics were analyzed using independent t-tests and category of variables by chi-square or Fisher exact t-test. P-value of less than 0.05 was considered to be significant. Coming to results, the two groups were comparable in terms of age, gender, baseline vitals, and comorbidities. Metabolic parameters were more favorable in terms of plasma light group as compared to the normal saline group. pH was statistically lower in the NS group at completion of anastomosis, p-value of 0.014, and end of the surgery, p-value of 0.1013. Base excess and bicarb values were also significantly different at the end of the surgery. These two are the graphs showing the trends of pH and base excess at various time points in the surgery. Electrolytes, total volume of crystalloids used intraoperatively, blood loss, urine output, and the end of the surgery and on the post of day 1, 2, 3 were comparable. Outcome parameters, graft viability, ICU state, hospital stay was also comparable between the two groups. Conclusion, plasma is associated with better acid-base status in the surgeries, and normal saline administration has worsened the acid-base status in the significant reduction in base excess pH and bicarb level after anastomosis and reperfusion of the graft. Normal saline should be used cautiously in head and neck free flap reconstruction surgeries. It was a limitation, single standard center study. Multiple factors are associated with metabolic danger, and we are using only intraoperative fluid use. We strongly recommend a randomized control trial to be done for this effectiveness of the surgery. These are the references. Thank you.
So, Dr. Saurabh, are you there? The presenter is there. Dr. Saurabh is there. If the presenter is not there, we can move on to the next session, next presentation.
Good morning. My name is Dr. Smith. I am presenting the study breath holding time for preoperative assessment of patient undergoing elective suprainguinal vascular surgeries. Major suprainguinal vascular surgeries are high-risk surgeries and often performed in geriatric patients with multiple comorbidities. Various tools to measure the functional capacity of these patients are cardiopulmonary exercise testing, stress myocardial perfusion imaging, Duke activity status index, etc. But they are expensive and their availability is very limited. So primary objective of our study is to assess whether breath holding time is able to predict post-operative cardiopulmonary complications and mortality. Second is comparing breath holding time with 2D echo and spirometry in prediction of cardiopulmonary complications. What are the incidence of cardiopulmonary complications and early post-operative mortality? It's a prospective single-center observational study completed at Nehru Hospital from January 22 to June 23, and sample size was 30. Inclusion criteria were adult patient with chronic limb ischemia posted for elective aortoiliofemoral bypass and elective abdominal aortic aneurysm repair. Patient refusal and emergency surgery were exclusion criteria. All patients were routinely assessed according to the ACC guidelines, and Duke Activity Status Index questionnaire, VSC CRI, Scott questionnaire were completed on the day of recruitment. Room air saturation, baseline echo, and PFT were done in every patient. Breath holding time was performed in all patients. Patient was asked to sit comfortably on a chair with inspire maximum after a maximum expiration and hold it for a maximum duration. This procedure was repeated 3 times with the 5 minutes interval. ABG, chest X-ray, and 12-lead ECG, troponin 1 were done at the baseline and were repeated at the post of day 0, 1, and 2 for diagnosing any cardiopulmonary complication. Research term follow the study participant daily throughout their hospital stay, and continuous saturation monitoring was done. After hospital discharge, participants were contacted telephonically or on the follow-up. After 30 days, patients were divided into 2 groups: the patient who have cardiopulmonary complications present and cardiopulmonary complications absent. Different cardiopulmonary complications which were looked after, like non-fatal cardiac arrest, acute MI, congestive heart failure, new arrhythmia or unstable angina, and different cardiopulmonary complications were respiratory insufficiency, pleural effusion, atelectasis, or pulmonary edema. Statistical analysis. Independent t-test was used for continuous data. Chi-square was used for categorical data, and ROC curve was used to compare the prediction of post-operative complication by breath holding time, ejection fraction, DASI, and VSG score. This is the study flowchart. 41 patients were assessed for the eligibility, 34 were enrolled, and 30 patients were analyzed. Demographic analysis between the 2 groups were identical. Cardiopulmonary complications were seen in 10 patients, that accounts for the 33%. And respiratory insufficiency was present in 9 patients. Mortality was seen in 3 patients, that is 10% of the total study population, and acute myocardial ischemia was the reason. Breath holding time. was significantly different between the two groups, and p-value was 0.14. Apart from that, room air saturation, Duke activity status index, and ejection fraction were also significantly different. Best breath holding time with a 23 cutoff value have a sensitivity of 70% and specificity of 90%, with area under curve of 0.78, which was maximum as compared to ejection fraction and Duke activity status index score. Breath holding time can it can reliably assess the increased cardioreflex sensitivity in chronic heart failure, chronic lung injury, and CKD patients. It has two components. One is breath holding time, which is an indicator of chemoreflex sensitivity. Second is breath holding induced desaturation, which is an indicator of gas exchange deficit. Breath holding time performed better than other parameters because in vascular surgery cardiac risk assessment, almost 52% patients were carotid endarterectomy, which is an intermediate risk procedure. And Duke Activity Status Index is a long questionnaire, and it's more suitable for native English-speaking population. Our limitation of our study was it is a small sample size with only immediate outcomes, that is 30 days mortality. Conclusion: breath holding time can reliably predict probability of 30 days post-operative cardiopulmonary complication and 30-day mortality in patient undergoing suprainguinal vascular surgeries. Thank you.
Do we have the presenter here for question answers? If the presenter is not there, we can go on to the next presentation.
Madam, these presenters are actually presented yesterday.
So why is this session happening again today?
Some presenters actually they have not responded. Actually, that's why I think they have repeated, but they have already attended yesterday. The Dr. Saurabh and this one.
Okay.
They only the ones now who did not present yesterday.
So if you have a proper list who has presented, who has not presented, please play those, as Dr. Rahil is telling. Please play only those who have not presented, because they will not be here also, no? Then.
Okay, ma'am.
Good morning, everybody. Myself, Dr. Hina Saini. I'm presently working as fellow at Tata Medical Center, Kolkata. The topic of my presentation is factors responsible for postoperative mechanical ventilation following HIPEC, a retrospective analysis. Cytoreductive surgeries followed by HIPEC is the standard treatment option now for peritoneal carcinomatosis, which has improved survival rates significantly. It's a complex and lengthy surgery involving extensive peritoneal and multivisceral resection, followed by perfusion of the peritoneal cavity with heated chemotherapeutic agent for 60 to 90 minutes at 42 to 43 degrees Celsius and performing multiple anastomosis. There may be significant fluid shift, blood, fluid, and protein loss. Aim of the study was to retrospectively examine and analyze the perioperative factors that can be responsible for failure to extubate at the end of surgery, leading to post-op mechanical ventilation. It was a retrospective analysis of study with a study period of from July 2014 to 2019. Perioperative data of 50 patients who underwent CRS HIPEC at a study was collected and analyzed, and data was collected from hospital electronic database and REDCap data collection. There were no exclusion criteria. Analysis was carried out with SPSS version 17. Out of total 50 patients, 54 patients were extubated on table, while 46% of patients were put on elective mechanical ventilation. Patients with high mean PCI of around 20 were put on elective post-op ventilation. Patients who had longer anesthesia and surgical time were put on elective post-op ventilation, whereas intraoperative fluid requirement was comparable between the two groups. Patients who had higher colloid requirement, higher blood transfusion requirement were put on elective post-op ventilation.
Respected dignitaries, I am presenting a paper of comparative study of efficacy of intrathecal injection of hyperbaric bupivacaine with fentanyl versus hyperbaric bupivacaine with dexmedetomidine in lower abdominal surgeries as prospective randomized study. Spinal anesthesia is most preferred mode of anesthesia for lower abdominal surgeries as it is easy to perform, economical, and provides effective longer duration with less postoperative complication. But using single drug plain bupivacaine has its disadvantages like shorter duration of action, delayed onset, and frequently overcome this frequently used adjuvants like adrenaline, tramadol, fentanyl, clonidine has effects that shorten the onset of block, prolong the duration of block, and effective postoperative analgesia. Fentanyl is a synthetic opioid, acts on mu receptors, and by that provides the analgesia and longer duration of sensory and motor block. The dexmedetomidine hydrochloride is a newly highly selective alpha-2 agonist, and by that it provides the sedative, analgesic, and anxiolytic effects. Therefore, the aim of the study was to perform and to determine the time of onset or duration of sensory and motor block and postoperative analgesia and efficacy of dexmedetomidine with fentanyl adjuvant to bupivacaine in spinal anesthesia in lower abdominal surgeries, with the aim of the study to evaluate the efficacy of dexmedetomidine in comparison to fentanyl as an adjuvant to bupivacaine for subarachnoid block in lower abdominal surgeries. Onset and duration of sensory block, onset and duration of motor block, and duration of postoperative analgesia were primary objectives, and intraoperative hemodynamic changes and adverse effect of study drugs were secondary objectives. It was the prospective double-blind randomized study conducted at GMS Medical College, and the sample technique was probability sampling technique. And sample size were of 100 patients were divided in two groups. Group F fentanyl, group D dexmedetomidine contains 50 participants in each group. Randomization was done by coin toss method for each patient, and drug preparation data collection was done by anesthesiologist who was not a part of study group. Group F received 3 ml of 0.5% injection hyperbaric bupivacaine plus 25 microgram fentanyl, and Group D received 3 ml of 0.5% injection hyperbaric bupivacaine plus 5 microgram dexmedetomidine. Both the group received 3.5 ml of total volume. Sensory block was assessed by pinprick method, and motor block was assessed by modified Bromine scale. Both after 2 minutes of subarachnoid block for 10 minutes, then after 5 minutes for next 20 minutes, and then after 30 minutes for next 2 hours. And visual analog score used as duration of analgesia counted from injection to need of first dose of analgesia. Supplemental analgesia with injection diclofenac was given when the VAS score is greater than 4. Secondary outcomes were measured, and data analysis and statistical chartings were done. So it shows that demographic data like age, sex, weight, height, ESA grading were comparable in both the study groups. Primary outcome, that is sensory block and motor block onset in both the study groups, were significantly lower in Group D compared to Group F. And mean time of onset of motor block in Group D was significantly lower than the Group F. And the time required for maximum sensory and motor block was significantly lower in a Group D compared to Group F. Duration of sensory analgesia and motor block was comparatively higher in a Group D compared to Group F, and it was statistically significant. Comparison of postoperative pain using visual analog score shows that it was lower in a Group D at 6, 12, 18, and 24 hours and compared to Group F as compared to Group F. Secondary outcomes were measured, and they were comparable with both the groups, and so that the spinal anesthesia has emerged as important regional anesthesia technique and simple to administer with effective and reliable and economical. And so using adjuvants to bupivacaine hydrochloride, it results shows with comparative other studies, and our study conclude that the dexmedetomidine is better adjuvant than fentanyl as it provides rapid onset and prolonged sensory and motor block, hemodynamic stability with excellent postoperative analgesia. These are the references, and thank you.
Dr. Urvi is there?
Yes, ma'am. I'm present. Good morning, ma'am.
Good morning. Dr. Rahil, you have questions to ask?
I wanted to ask, how did you reach at the sample size of 100 in this particular study?
Ma'am, according to the patient flow in our setup hospital, and plus using a visual analog score as a primary outcome, my statistician has used this primary comparative study which I have mentioned in my references, and according to that I have measured the study group 150 participants in each group.
Did you see any complications with the dexmed group?
No, ma'am. My study has shown only 50 participants, and none of them has like bradycardia or hypertension has not been occurred. So no complications were recorded in dexmedetomidine group, ma'am.
And also the fentanyl.
No, ma'am. Fentanyl has one patient has a nausea and vomiting, complaint of nausea and vomiting, and one patient has complaint of pruritus, rashes occur. So we have then given her the Evil Dexona we have given for that patient also, sir. Also, ma'am. But it was just a one patient, so it was not statistically significant, ma'am.
Okay, Dr. Urvi, what is the status of dexmedetomidine to be given for subarachnoid block as per FDA? Is it approved to be given in subarachnoid block as per FDA approval?
Ma'am, except then the pregnant patients, we are using dexmedetomidine in our setup in lower abdominal surgeries, also in a vaginal hysterectomy, abdominal hysterectomy, plus the tibia or fibula fracture or any hip fracture. If we are planning to give the spinal anesthesia, then yes, we are using the dexmedetomidine in a lower abdominal surgeries in a subarachnoid block, but we are not using it in pregnant patients. And because this study
what about the FDA approval of this drug for subarachnoid block?
Ma'am, I actually not very much aware of that.
Okay, and what kind of dexmedetomidine you use? Preservative free or with preservative? Because
no, ma'am, it is a preservative free. It was a preservative free. In our setup, it is come as a preservative free drug, ma'am.
Okay. Okay, we can go on to the next.
Thank you, ma'am.
Greetings all, this is Dr. Deepti, third year postgraduate student from SMS Medical College and attached group of hospitals, Jaipur. I shall be presenting my paper on the topic, a comparative study on attenuation of hemodynamic response to extubation, esmolol versus propofol, a comparative randomized double-blind interventional study done under the guidance of Dr. Fareed Ahmed. A little background check. Tracheal extubation is almost always associated with hemodynamic changes, which could be detrimental to the patient, as this increase in sympathoadrenal activity might result in hypertension, myocardial insufficiency, and cerebrovascular diseases. Despite that extubation is such an important step in our practice of anesthesiology, smooth extubation techniques are almost and always neglected. Compared to intubation, extubation has been less studied, and there is paucity of literature with regards to extubation technique. Thus, we did this study to evaluate the ability of esmolol and propofol in attenuation of cardiovascular response to tracheal extubation. The primary objective of this study was to determine the difference in post-extubation systolic blood pressure, diastolic blood pressure, mean arterial pressure, and heart rate from baseline. The secondary objective was to determine the difference in proportion of cases experiencing side effects, if any. The study was done at SMS Medical College and attached group of hospitals, Jaipur, in 72 eligible patients undergoing abdominal surgery. The patients were divided randomly into two equal groups consisting of 36 patients each. Group A received IV esmolol 1.5 mg per kg, while Group B received propofol 0.5 mg per kg. The main interventional step was 2 minutes prior to extubation when the study drug was administered, following which vitals were noted at the time of extubation as well as 1, 3, 5, and 10 minutes post-extubation. The data was analyzed using chi-square and student t-test. Both of the groups were comparable with regards to age, as could be seen in this table, and also with regards to weight, as could be seen in this table. Both of the groups were comparable with regards to baseline mean heart rate amongst both the groups, as could be seen in this table. Baseline is seen as the time before the administration of the study drug. Following administration of the study drug, there was fall in heart rate in both of the groups, and it was significant. However, the fall was more in Group A as compared to Group B, as could be seen in this table, and was significant till 10 minutes post-extubation, as could be seen in this table as well as in this chart. The systolic blood pressure, diastolic blood pressure, as well as the mean arterial pressure were comparable amongst both the groups at the time of baseline. Following the administration of the study drug, there was fall in all the three parameters in the two groups. However, the fall was much more in Group A as compared to Group B, and it was significant till 1 minute post-extubation. Following 1 minute, both of the groups were comparable with regards to systolic blood pressure, diastolic blood pressure, and mean arterial pressure, as could be seen in this table as well as in this chart. The diastolic blood pressure, and this is the mean arterial pressure. We did not find side effects in relation to hypotension, bradycardia, nausea, vomiting, or allergic reactions to the drug in any of the groups. Our study was consistent with the study done by M.H. Negrel in 2015, where they concluded that esmolol was a better drug as compared to lignocaine and propofol in attenuation of hemodynamic response to extubation. Our study is also consistent with the study done by Konda Sunil Kumar in 2018, that esmolol is a better drug as compared to propofol in attenuation of the hemodynamic response to extubation. Thus, our study concluded that esmolol was more effective in controlling hemodynamics as compared to propofol, and thus is a better drug to attenuate extubation response as compared to propofol. Thank you.
Dr. Deepti is there?
Yes, ma'am.
Dr. Rahil, you may start.
I wanted to ask that you are giving propofol just before extubation. Did you see?
Yes,
any,
ma'am.
Actually, this technique became very popular. It was called as a sandwich technique, but later outrightly rejected because the patients were excessively sedated. If you give propofol just before extubation, the patients become sedated. Did you experience anything like that? Because you have actually not, this was not your secondary outcome, and you did not observe that in the patients. You did not actually monitor that in the patients. You should have done that.
Ma'am, actually, we just noticed it in, I think, 2 patients of mine were sedated, but all were sedated as the dose which I gave was 0.5 mg per kg.
Quite a significant
And
dose if you give at the time of extubation, just before extubation, example, you are giving 15-20 milligram of propofol. It actually, patients become excessively sedated, and that is why it was outrightly rejected. The sandwich technique, if you had heard or you would have read your textbooks. So I believe that you should have, monitored that as well, the sedation scores at the end of the, between the propofol and esmolol. Obviously, it will be more in the propofol.
Yes, ma'am. Ma'am, but I actually monitored my patients for 10 minutes post-extubation, but I just saw that in 2 patients and not in more than that, because my age group was of patients. It was 20 to 40 years of patients which I chose. Once I administered it in a patient was of...
But this was not your secondary outcome, right?
Yes, ma'am.
It was not in your secondary outcome?
Yes, ma'am.
Okay.
It's true,
Yes,
if you're
ma'am,
giving
it was
an
not in my
IV
secondary
anesthetic at the end of extubation, at the time of extubation, the sedation score should have been part of your methodology. And
Yes, ma'am.
second, how do you select that you would choose patients between 20 to 40 years? Because usually we'll have adult patients at least 18 to 60 years. And how did you choose the dose of esmolol 1.5 mg per kg? That's not the actual textbook dose.
Ma'am, the esmolol dose, I saw many hours on the internet, and I also assessed it when I gave my drug. So it was most when I gave it in a dose of 1.5 mg per kg. And I saw on the mentioned that this was the most effective dose during the time of...
Sorry to interrupt you, but if you have a patient who's 60 kgs, so 1.5 mg per kg,
Yes,
that means you're going to give 90 milligrams of esmolol at the time of extubation.
Yes,
that's going
ma'am.
to cause profound bradycardia. That's what is the dose of esmolol as per the textbook?
Ma'am, actually, the dose we see is during intra-op, which is 0.5 mg per kg. But when I saw at the time of intubation response or extubation response, it was mentioned as 1.5 mg per kg.
So you did not
also
notice any
that there are
bradycardia?
many studies that... No, ma'am, no. I did not notice any bradycardia. And further, before the drug, I actually evaluated the heart rate, the heart rate which was ongoing. So when it was 90 or more than that, then only I administered the drug. If it was 70, 60, I did not administer those patients.
But you did not mention those excluded patients in your study, in which you did not give esmolol because they had a lower baseline heart rate.
Yes, ma'am.
So, and what is different? What is new in your study? Because there are a lot of studies which have been done in which people have given different things for extubation. So, how the study is different and what is unique?
Just that I wanted some, these are mostly easily available in our institute, esmolol and propofol, and it is not that they are not that costly also. So administering pharmacologically, these, I found that they had a very good impact when I saw the patient post extubation, particularly esmolol, because I did not see any of my patients who were experiencing any
or sore throat, which I found in other patients of mine in which nothing was done.
Okay, thank you.
Thank you.
We can go on to the next presentation.
Hello everybody, my topic is septicemia in critically ill patient, prospective study on epidemiology risk factors and role of maldito of MS for species identification causing septicemia. Severe sepsis and septic shock is a major determinant, one of the major determinant of survival or mortality in ICU, with mortality as high of 40 to 60%. Empirical use of broad spectrum antibiotics has led to increased number of multi-drug resistant strain, posing a unique dilemma to maintain a balance. So need of the hour is to develop a practice which is based on quick species identification and use of antibiotics based on susceptibility pattern. Metric assisted laser desorption, ionization, time of flight, mass spectroscopy is one such method. Is fast, accurate, cost effective, and ease of sample preparation, identification species from blood cultures, resulting in time reduction and fast result. It's an analytical methods based on mass to charge ratio and the time travel in the time of flight tube, and plotted on the graph, which is compared with the algorithm already known to the microorganisms. Aims and objectives is to study epidemiology and risk factors of causative organisms, role of maldito of MS in species identification, and clinical outcome in terms of ICU stay. Study was conducted in a trauma ventilatory unit in Department of Anesthesiology, KGMU, Lucknow, of 1 year duration. Prospective cross-sectional study sampling is done with convenience non-probability sampling. Sample size was 200. These are the inclusion and exclusion criteria. Patient giving consent, age of 60 to 60 years, patient having new onset of fever after 48 hours of admission in the hospital or new onset neutropenia. Study performed in TVU. After taking consent, patient samples were sent, multiple samples were set, and antibiotics are started based on the reporting done by maldito of MS and susceptibility. Treatment was monitored and clinical outcome was noted. Cases were followed till patient is discharged, shifted to parent unit or mortality. These are all of my results. In our study, we found most common organism isolated from ETS spread was Acinetobacter baumannii, followed by Klebsiella pneumoniae, E. coli. In urine, it was Candida unknown albicans. In blood, it was Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter baumannii. Our results are consistent with increased trend of gram-negative septicemia in ICU, and this has led to early diagnosis and specific intervention as to initiate specific antibiotics and early shifting from empirical to specific therapy. Traditional technique usually take 4 to 5 days, which delays the process. While in 2000 conducted a study to validate the efficacy, they stated that the accuracy of maldito of MS is 84% for species and 92% for genus. Richard J. et al. In 2009 studied the benefits and limitations of maldito of MS. They concluded that adoption of maldito of MS in clinical microbiology laboratory is revolutionizing infectious disease diagnosis and critical care. Shifting from empirical to specific therapy have advantage in more cost effective and decreasing the incidence of resistance. We also study the risk factors, but our data is inconclusive to draw results. Major advantage of using maldito that it reduces time between blood drawn and recipient of results about organism causing septicemia. Our findings are considered with previous studies proving efficacy of maldito in critical patient. We collected data for mortality, but although it has no maldito has no mortality benefit, as mortality is a multifactorial and clearly don't depend upon one factors. So early initiation and de-escalation and reduction ICU stay are the main purpose of our studies. To conclude, our hospital stay of the patient were of 12.89 with standard deviation of 6.5. There was no significant difference when mortality when growth is either in ET or urine. But if positive growth was in blood, the mortality is as high as 56.8 as compared to 36 in sterile. If we observe positive growth in ET is resistant to all drug, then mortality was 60.6. Present study has a limitation as it is a single center studies and antibiogram and organism may not reflect the actual burden. There is no data to compare results of maldito of MS with traditional methods. Due to COVID-19 infection, results become incomparable to the past. So in conclusion, our results shows that use of maldito of MS has a potential to replace traditional method of species identification, and routine use will have a mortality benefit in patients of septicemia, as sepsis management is time specific. It has a role in early initiation of specific therapy, early de-escalation of treatment. Further studies are required to justify its use. Stop share.
Do we have Dr. Kuldeep here?
Yes, good morning.
Good morning, Dr. Kuldeep. What was your study design? A prospective cross-sectional study. So what did you do in that? How do you justify that this is a cross-sectional study?
Ma'am, I selected the patients based on my reference study. So what all patients who are admitted in our ICU, earlier we used to send samples from for traditional cultures. But after the introduction of maldito of MS in microbiology departments, all of our patients are going for the maldito of MS species identification. So we sent samples for patients, and based on the species identified by the machine, we changes our antibiogram of that ICU and the statin management based on that. Not only we didn't intervene, we didn't add to it. So it's an observational study, and it happens only for 1 year of duration only.
Yeah, that's true. I agree. It is a prospective observational cohort study. How it is cross-sectional study? What is the definition of a cross-sectional study?
It is the cross-sectional study because we got a data to compare mildly of MS results with the traditional, which we were using for past 2 years. So I have to take back dated to 2 years back also to compare my results with present ISU cultures. So that's why it is a cross-sectional study.
Okay, Dr. Rahil.
How much time does it take for this new technique for the results to be out?
Yes, ma'am. Sorry.
How much time does it take for the culture report to come out?
Ma'am, if sample is prepared, it will take 15 to 20 minutes only, ma'am. But it provided it has to be growth should be there in the sample. It will take growth will take 24 hours, ma'am. But as soon as we prepare the matrix, which we call from a smear, it will match with the algorithms and it will identify species in maximum to 20-30 minutes, ma'am. So compared to earlier results, it will take earlier traditional methods will take 4 to 5 days to give our organisms. But in mildly of MS, maximum at earlier we can get our results in 24 hours.
How much? How economical it is? I mean, how much does it cost?
It has initial setup cost, but once you have installed it, then the cost effectiveness is there.
So how much was your total sample size?
My total sample size was 200 patients.
200?
200 patients, yes, ma'am. Showing positive growth.
Over the period of 1 year?
Yes, ma'am. Our 1 year admission in ICU is 1,000, around 1,000 for past 3 years, ma'am.
So over the period of 1 year, you selected only 200 patients?
Yes, ma'am, because of the incidence of sepsis, I calculated from Sharmila Chatterjee et al., published in Indian Journal of Critical Care in 2017, on the basis of incidence of severe sepsis and sepsis in ICU. I have to select the patients who shows positive growth only, ma'am. Should be a case of sepsis, fever after 48 hours of admission. That's why the sample size is 2.
What is your ICU type? It is a surgical ICU, medical ICU, or a mixed?
Ma'am, it's a mixed only, ma'am. It's a tertiary level ICU care. We get patients from neurosurgery, post-operative care also, trauma also. It's in trauma center.
That is why maybe the incidence of sepsis is less, because if you have a medical ICU, approximately 60% patients would be sepsis only.
We take post-op case also, ma'am. And trauma patients also.
Right. Okay, thank you.
Thank you.
We can go on to the next presentation. Do we have more?
Myself, Dr. Parthivan Vargama from PD Government Medical College, Rajkot. My e-paper topic is evaluation of cisatrachyrium and atrachyrium basalate in patients undergoing abdominal procedures under general anesthesia. Introduction. Atrachyrium and cisatrachyrium both are intermediate-acting non-depolarizing muscle reactions. Cisatrachyrium is an isomer of atrachyrium and is devised of histamine-induced cardiovascular adverse effects. The potency of neuromuscular blocking effect of cisatrachyrium is approximately 3-fold that of atrachyrium. Aim to compare cisatrachyrium and atrachyrium by various perspectives, including efficacy, neuromuscular blockade, changes in hemodynamic parameters, and safety profile. Objectives to compare atrachyrium and cisatrachyrium in terms of onset, duration of action, of first loading dose, 25% recovery of TOF ratio after last supplemental dose, and intubating conditions. To compare changes in hemodynamic parameters after administration of loading dose and maintenance dose of both the drugs. To compare safety profile of both the drugs in terms of adverse effects. Materials and methods. A prospective randomized double-blind study was carried out on patients after approval of Institutional Ethics Committee, PDU Medical College, Rajkot. Patients allocated randomly into 2 groups, 30 in each group. Group C and Group A. In Group C, injection cisatrachyrium was given as per the dose mentioned on the slide. In Group A, injection atrachyrium was given as per the dose mentioned on the slide. Inclusion criteria. All the patients of age 18 to 65 years of either sex having AS grading 3, 4, or 5 admitted for abdominal surgery under general anesthesia. Exclusion criteria. Patient's refusal patients who are taking medications known to interact with neuromuscular blocking drugs, patients having cardiac, renal, or hepatic impairment, or having neuromuscular system disorders, pregnant or lactating women. Sample size estimation, assuming 90% statistical power and formula given on the slide, we have calculated the sample size of 30. Considering dropouts and failure, we have taken 35 cases in each study group. Patients who standard injection were done after pre-medication and pre-oxygenation, and muscle relaxation was given in group A with injection atracurium and in group C with injection cisatracurium as per the doses mentioned on the slide. After the induction, hemodynamic parameters were monitored and neuromuscular monitoring were done and complications were observed if any. Onset of time determined from end of the muscle relaxation injection till top ratio 0. Duration of action was determined from the end of drug injection till 25% recovery from top score 2. Time of repeated injection when top score is 2. At the end of surgery, reversal is done with injection neostigmine and glycopyrrolate. Statistical analysis, quantitative data was analyzed by unpaired student t-test and qualitative data was analyzed by chi-square test. If p-value was less than 0.05, it is deemed as statistical significant difference. Results, demographic data like age, sex, weight, and ASI rating were almost comparable in both the groups. There is statistically significant increase in heart rate, systolic BP, diastolic BP, and mean BP just after intubation after 5 minutes, 10 minutes, and 15 minutes of intubation in group A, then group C. Intubating conditions like jaw relaxation, laryngoscopy, vocal cord movements, coughing, and limb movements were almost comparable in both the groups. Neuromuscular monitoring. There is a significant early onset in group A, then group C, as shown in graph. There is a significant longer duration of action in group C than group A. 25% recovery time of last supplemental dose was significantly longer in group C than group A. Safety profile, there was hypotension in 2 patients in group A and arrhythmia in 1 patient in group A. No such complication observed in group C. Discussion, our results was evidenced by the study of A.M. Al-Kasabi, Jabalami, Rachna Bakshi et al., Bluestein et al., and M.T. Carroll et al. Future scope and limitations, larger sample size with different duration of surgical procedure along with safety profiles with different dosages can be evaluated and studied further. From our study, we have seen that cisatracurium can be better, has better hemodynamic stability, early onset, longer duration of action, better safety profile as compared to atracurium. Both drugs having similar profile in terms of intubating conditions. Thus, we have concluded that cisatracurium can be better alternative to atracurium basal. References.
Presenter is there, Dr. Parth Kumar. Do we have the presenter here? If the presenter has not signed in, we can go on to the next then. Please proceed to next presentation.
Good morning, everyone. This is Dr. Adiba Shabnam. I'm here to present my paper, which is comparative study of effect of early tracheostomy and prolonged intubation patients requiring long-term mechanical ventilation. Advances and improvements in healthcare nowadays have increased the need of prolonged ventilatory support among critical illnesses in ICU. Airway access for mechanical ventilation can be provided either by an endotracheal tube or a tracheostomy tube. Most patients with respiratory failure are ventilated through an endotracheal tube generally, but changing this to tracheostomy tube is often considered when there is a prolonged ventilation requirement. Hence, here is an attempt by me to assess if early tracheostomy overweighs the risk of prolonged endotracheal intubation. The aims and objectives of my study are to compare the effects of early tracheostomy versus prolonged intubation in ICU in patients who require long-term mechanical ventilation in terms of duration of ventilatory support, length of ICU stay, and incidence of ventilator-associated pneumonia. I have selected 60 patients admitted into ICU who are of age 15 to 55 years, and the informed written consent was taken from the patient attenders. And the two groups were made ensure that they are similar in mean age-sex ratio diagnosis at the time of ICU admission. These patients were divided into tracheostomy group and the intubation group. Tracheostomy group patients Surgically, tracheostomy was done from day 3 to day 10 of intubation. And intubation group, the patients were intubated throughout their hospital stay until extubation or death. Age-wise, the two groups were ensured that the mean age was around 30 years in both the groups. And sex-wise, both the groups were ensured that 70% of the group is constituted by males and 30% is by females. Duration of mechanical ventilation was observed to be 11.9 days in intubation group and 9.3 days in tracheostomy group. Statistically significant difference was observed. Whereas the length of ICU stay in intubation group was 14.6 days and tracheostomy group was 11.3 days, which was also statistically significant. The intubation group mean duration of mechanical ventilation after ventilator-associated pneumonia was 7.2 days, whereas in tracheostomy group it was 4.9 days. Statistically low significance was observed. Thus, the results, I would like to say that there is a decrease in mean duration of mechanical ventilation in tracheostomy group and the length of ICU stay was less in tracheostomy group. However, incidence of VAP was statistically insignificant in both the groups, but the duration of mechanical ventilation after VAP was around 5 days in tracheostomy group and 7 days in intubation group with the lower statistical significance. Tracheostomy is one of the oldest performed procedures frequently performed in ICU. It is a surgical procedure in which the anterior aspect of the neck we create an incision and via that stroma we try to put a tracheostomy tube. In acute settings, it is generally indicated for severe facial trauma, angioedema, tumors of head and the neck, whereas in long-term chronic settings, we do it in patients requiring long-term mechanical ventilation. It is recommended because it also provides better respiratory mechanics, nutrition, patient comfort, etc. Laryngeotracheal injuries constitute an important element for specifying the optimal moment for performing tracheostomy. However, that optimal moment is controversial. It depends on the clinical situation and individual preference. I would like to say that tracheostomy has helped us to increase the patient mobility, more secure airway, increase the patient comfort, improve airway suctioning, less direct endolaryngeal injury, better oral nutrition, enhance phonation communication, decrease chances of nosocomial pneumonia in patient subgroups. I would like to conclude that early tracheostomy has led us to decrease duration of mechanical ventilation and decrease the length of ICU stay, decrease the duration of mechanical ventilation after ventilator-associated pneumonia. Thank you.
Dr. Adiba, you're there for discussion? Do we have the presenter here for discussion?
Maybe we can go to the next one.
Yes. Found the study quite unethical that you keep the patient intubated till their mortality.
I also wanted to ask that. How can you, for the purpose of the study, even beyond 10 days, they kept the patient on ventilator and intubated?
Yeah, it just looked like it had a lot of ethical concerns, actually.
Yes. Are there any more studies left?
Myself, Dr. Anjali. The topic of my study is comparison of acromion-axillary sternal notch index, thyromental height test, and modified Malambati test in pre-anesthetic prediction of typical laryngoscopy. Unanticipated difficult airway following induction of anesthesia is a challenge and a prime concern to anesthesiologists owing to undesirable respiratory and cardiac outcomes and other related complications. In the study, our aim is to compare the diagnostic accuracy of the two new tests, acromion-axillary sternal notch index and thyromental height test. Method: observation analytical cross-sectional study. conducted in Department of Anesthesia, Pushpagiri Institute of Medical Science and Research Center, Tiruvalla, Kerala. Institutional ethical clearance and clinical registration number was obtained. Inclusion criteria: age 18 to 65 years, both genders, ASA 1 and 2. And exclusion criteria included known difficult airways, emergency cases, pregnant patients, neuromuscular disease, awake intubation, morbidly obese patients not willing to give written consent. Proper methodology: consecutive sampling till study number of patient was obtained was done. Patient demographic was assessed and physical examination performed by an independent researcher who was not involved in subsequent data collection intraoperatively. Direct laryngoscopy was done by a trained senior anesthesiologist unaware of pre-anesthetic acromiaxillary sternal notch index and TMHT value to assess Cormack and Lehen grading. Sample size obtained after calculation was 358. The following predictive measurements was taken in physical examination: ASA and thyromental height. In statistical analysis, demographics, age uniform distribution of age was seen. In sensitivity comparison of acromiaxillary sternal notch index, thyromental height test, ASA showed a higher sensitivity compared to TMHT and MMT. Then specificity and compared, acromiaxillary sternal notch had a higher specificity, but thyromental height also had a more higher specificity compared to ASA. In result, thyromental height test sensitivity was 6.8% and specificity 94.4%. The maximum measurement observed was 90 millimeter and the minimum was 35. The mean value was 62. Diagnostic accuracy of thyromental height is 72.9%. ASA, our new indicator, showed a high sensitivity of 97.7% and a specificity of 90.4%. The diagnostic accuracy that got calculated was ASA is 92.2%. So discussion: numerous re-anesthetic airway assessment parameters and scoring systems based on physical examination findings have been proposed and tested. At present, pre-anesthetic airway evaluation remains the poorly quantified gestate estimates of chances for difficult laryngoscopy. So initially, thyromental height test was introduced by Tesadi et al. In the study, in which it had a higher specificity and sensitivity. TMHT appeared to be a promising single anatomical measure to predict the risk of difficult laryngoscopy. Then later in 2019, Yabuki et al. Also conducted a study. Many studies were conducted in thyromental height test. Then Kamran Manish et al. In 2013 published a study based on new index, acromiaxillary sternal notch index. The sensitivity of ASA in that was 78.9%, specificity of 89.4%. And followingly, any other studies were conducted on ASA. In conclusion, in our study, after analysis, we came to a conclusion that acromiaxillary sternal notch index is an ideal standalone pre-anesthetic predictor of difficult laryngoscopy with a high diagnostic accuracy. Whereas thyromental height test also showed a higher specificity, but the diagnostic accuracy was higher for acromiaxillary sternal notch index. Thank
you. Dr. Anjali is available?
Yes, ma'am. Good morning, ma'am.
Good morning, Dr. Anjali. I have a question. Why you only calculated sensitivity and specificity? We cannot conclude with these two parameters. So did you calculate the negative predictive, positive predictive, or area under the curve?
Yes, ma'am. We have calculated positive predictive value, negative predictive value. For thyromental height, the positive predictive value was only 28.6, and acromiaxillary, the positive predictive value came to 76.8%. And negative predictive value for thyromental was 75.7. Negative predictive for ASA was 99.2%. So with that, we concluded that it is more valid test, as a simple valid test in preoperative assessment.
I wanted to ask you, Dr. Anjali, how much was the sensitivity you said that thyromental height test in your study it came out to be?
The sensitivity was only 6.8%, ma'am.
But your parent particles had much higher sensitivity.
Yes, ma'am. Yes, ma'am.
Why is the reason? It was in 80s. In the parent article, it was around 80, 82%. Yes. In yours, it was 6%.
Yes, ma'am. The method, I only took the pre-op value. We took it in same method for all the patients, but using a vernier caliper, but it came when the analysis was done, the sensitivity was low for thyromental height.
Looks very odd. I mean, it's quite stark difference.
Yeah. So have you applied the Cohen's test and calculated the kappa and all to see the concordance between the clinical and?
No, ma'am. Only the diagnostic accuracy, sensitivity, specificity, and the predictive values.
I think you could do more analysis on your data. You may come out with something better.
Okay. Okay. Okay.
Analysis actually.
Okay. 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 Okay.
Okay.
Okay.
Thank you.
Thank you, ma'am.
Next, please.
Good morning to all the dignitaries present. I'm going to present the study on comparison of volume control versus pressure control mode of ventilation post-COVID mucormycosis patients undergoing FES under general anesthesia. COVID-19 caused by SARS-CoV-2 is associated with a wide range of opportunistic bacterial and fungal infections with a recent surge in mucormycosis cases, particularly in India. The definitive treatment consists of surgical debridement by FES, which is associated with the inflammatory changes in the pulmonary parenchyma, which provides a challenging situation to the anesthesiologist during intraoperative and immediate postoperative period. In this study, we assessed whether pressure control mode of ventilation provides an advantage over volume control mode. So the primary objective was to compare both the modes of ventilation in post-COVID mucormycosis patients, and the secondary objective was to compare the hemodynamic changes and ventilatory parameters. It was a hospital-based randomized control trial performed in KLES Dr. Prabhakar Kore Hospital in Belagavi, Karnataka for a duration of 3 months between May to July 2021. Inclusion criteria were patients aged between 18 to 80 years who were giving informed written consent and who were diagnosed to have post-COVID mucormycosis. Exclusion criteria was difficult airway, intracranial pathology, uncontrolled asthma, and who had already undergone mechanical ventilation for COVID-19. The sample size was calculated and was decided to have a minimum of 31 cases in each group. After obtaining ethical committee clearance and written informed consent, NDM status was confirmed, and during pre-anesthetic evaluation, CT severity score was noted in all patients. Baseline saturation, heart rate, and mean arterial pressure was recorded. After induction of general anesthesia, patients were randomly assigned to receive either volume control or pressure control mode of ventilation. The tidal volume was initially set at 8 ml per kg in both groups, and in PCV mode, the preset pressure was adjusted to attain the desired tidal volume. The ratio of IS/E and FiO2 was the same in both groups, and T per 5 centimeter of water was applied to both the groups. The following parameters, peak airway pressure, plateau pressure, tidal volume, EtCO2, heart rate, oxygen saturation, and mean arterial pressure were recorded for every 15 minutes for 60 minutes. And on statistical analysis, there was a male preponderance to the mucormycosis infection, with the age group of 50 to 59 being the most commonly involved, and most of them were ASA status 2. There was no significant difference between the mean values of SpO2, heart rate, mean arterial pressure, and EtCO2 between both the groups, while the peak airway pressure showed a significantly higher value as seen in this line graph in the volume control mode of ventilation when compared to the pressure control mode. Similar results were also seen in the mean plateau pressure readings also, with a higher reading in the volume control mode of ventilation. So as shown in the statistical analysis, VCV group had a significantly higher peak and plateau pressures when compared to the pressure control group. Though volume control ventilation is the most commonly used mode of ventilation intraoperatively, it provides a fixed minute ventilation which may affect the airway pressure, especially in cases of acute lung injury. But in pressure control ventilation, the limiting pressure is set as the target pressure, and the delivered volume is determined by the lung compliance and the airway resistance. Hence, this target pressure is set within the safe limits. This study used only CT severity score as the tool to assess the severity of pulmonary involvement. Tests like pulmonary function test could have been done in the preoperative period to have a better idea on the lung mechanics, and intraoperative monitoring was done only for 60 minutes. Hence, functional improvement in the postoperative period could not be assessed or documented. So in conclusion, the main principle in acute respiratory failure is to prevent or reduce the ongoing lung injury and support the organ function until recovery. The PCV mode has a distinguishing characteristic in that it delivers a constant pressure, resulting in a decelerating flow and a more even distribution of ventilation in patients with poor lung compliance. So these are my references, and thank you.
Dr. Priyadarshini is available?
Yes, ma'am. Good morning, ma'am.
Good morning, Dr. Priyadarshini. Why did you choose this group of patients? They had post-COVID mucor, but there was a lot of these patients, more than 90% of these patients never had any lung issues. So what made you select to this group of patients for comparison of ventilation modes?
Yes, ma'am. So there was a surge in mucormycosis cases, ma'am. We just wanted to compare, we just wanted to evaluate and see which mode of ventilation would be better in these patients, whether there was any associated lung injury actually, which could result in complication during the intraoperative ventilation.
And why did you choose patients from the age group of 18 to 80 years? The above 65 would be the geriatric age group. So they will have a lot of respiratory differences, isn't it?
Yes, ma'am. We decided to choose those patients, ma'am, most of them were within the age group of 50 to 60 only, and around only less than 10 patients came above the age group of 60.
So isn't it a study bias that you are showing in pressure control group and volume control? You are showing that peak pressure you are comparing. So in pressure control group, it is already in your hand to set the peak pressure, isn't it? So isn't it a study bias that you have the outcome of one group in your hand? So you may select a lower, you may select a higher. And what tidal volume did you select for these patients? Like how many ml per kg of tidal volume did you select?
Yes, ma'am. So the initial tidal volume is kept at 8 ml per kg, ma'am. So in the pressure control mode also, the pressure was set to deliver the tidal volume around 8 ml per kg. And ETCO2 also was monitored, ma'am. So it was kept between 30 to 35. So based on that, variations in tidal volume and respiratory rate was allowed. Yes, ma'am. As you said, in pressure control mode, we had the hand in choosing the pressures accordingly, but still volume control mode had a higher pressures recorded, ma'am. So most of the post-COVID patients are said to have an ARDS kind of feature, ma'am. So we just wanted to confirm whether it is the same. Like in ARDS, how they say pressure control mode is better than volume control, and low volume ventilation is better. So we just wanted to confirm whether pressure control is efficient.
You did any arterial blood gas analysis during the comparison of two modes of ventilation for a surgery lasting almost an hour?
No, ma'am, we didn't do. That was one of the limitations, ma'am. Only baseline CT severity score was taken into account, and there was no correlation between the CT severity score also, ma'am. Matlab, if the score was high, also there was no much difference in the airway pressure. Like if the score is higher, there was no higher pressures recorded. So only that was done. No PFTs or no ABG was done. So that was one limitation in our study.
You're saying that you took the baseline CT score into consideration. So you specifically got the CT done for the patients, or all the
no,
patients?
ma'am. Most of the patients had HRCT already done.
Most
ma'am,
of
because
if they didn't have, then?
If they didn't have, then we had gotten it done, ma'am. So all the patients had CT severity.
For the purpose of your study?
Ma'am?
Just for the purpose of your study, you got the CT done?
No, ma'am. For routine pre-op evaluation also, if the patients didn't have the CT score, we asked them to get it done, ma'am. Like if they didn't have an HRCT, we asked them to get it done.
Routinely for all mucor patients. We are also doing mucor,
yes,
but
ma'am.
we don't ask for the CT for the patients. Do you think it is ethically right to get the CT done for the patients just for the purpose of your study?
But in our setup, HRCT was required, ma'am. Even if they didn't have a proven RT-PCR, at least HRCT score was required, ma'am, during that time when there was a surge in mucor cases.
So in the
active
stage, I understand, because that actually tells you how much treatment to give, whether to start the steroids or not. Once the patient is over this, has tided over the acute phase, and now he's in mucor. So why do you need to get the CT done? Once the acute phase is over, the COVID is over, now the patient has come with the mucor, right?
Yes,
so what is the need to get the CT done?
Just to know about the pulmonary involvement only.
Or just for the purpose of your study, right? It's not ethically right to expose the patient. Already the patient has so much of mucor, and you are exposing them to CT radiation. Ideally, it is not required. I think PFT would have been a better option. Is that all?
Yeah.
Okay, thank you.
Hello, ma'am. And the next presenter is not here. So can you skip his presentation?
मीटिंग में तो बाहर निकले हो
Next presentation.
Good morning, everyone. Myself, Dr. Sumitra from Karnataka Institute of Medical Science. I'll present a paper on comparative evaluation of supplement vein catheterization using supraclavicular versus infraclavicular approach, a prospective randomized comparative study. First is introduction. Central venous catheterization is a time-tested technique of rapidly assessing the central nervous system. It is used in critically ill patients and those undergoing major surgery for monitoring technologies. The aim of the study is to compare the supraclavicular and infraclavicular approaches for supplement vein catheterization. Primary objectives are to assess and compare the access time, number of attempts, and success rate of cannulation between two approaches. Secondary objectives are to assess and compare the ease of guidewire and catheter insertion and procedure complications like arterial puncture, pneumothorax, hematoma at puncture site between two approaches. Inclusion criteria are conscious patients belong to ASA grade 1 to 3, age more than 18 years, belong to either sex, medical, surgical, and ICU patients who can give informal written consent, require CVP monitoring and infusion of vasopressors and long-term fluid management in the ICU. Exclusion criteria are patients with infection at puncture site, urine coagulation profile, contralateral pneumothorax, dermatoclavicle, upper ribs, distorted anatomy of the neck. Methodology. Its study design, it is prospective randomized comparative study with sampling is by closed envelope method. After getting ethical clearance from our institution, 70 patients were divided into two groups with 35 patients in each group. Technique of insertion, supraclavicular approach. Clavicular sternal mastoid angle will be identified by asking the patients to raise his head by palpation. A needle attached with syringe will be inserted at clavicular sternal mastoid angle, bisecting at a direction of 45 degrees. The needle is directed towards the contralateral nipple. Infraclavicular approach, point of entry is 1 centimeter below the clavicle, junction of medial two-third and lateral one-third of the clavicle is noted. Direct the needle towards the suprasternal notch. Study parameters. Access time, it is defined as a time between first in puncture until successful placement of catheter. Number of attempts, procedure is abandoned after maximum 3 attempts. Complication will be observed on post-procedure chest x and will be documented. Statistical analysis data was entered into Microsoft Excel datasheet and were analyzed using SPS 22 version. Results are calculated by using a student t-test, which I-square test or Wizard exact t-test. Results. Demographic profile. Demographic profile between our two approaches are comparable. Access time, the main duration for supraclavicular approach is 4 minutes, whereas an infraclavicular approach is 5 minutes. Number of attempts, first attempt supraclavicular approach was cannulated in 88%, whereas in infraclavicular is 51%, which is statistically significant. Success or failure, successful placement in supraclavicular approach is 97%, whereas in infraclavicular approach is 88%, which is statistically significant. Complications. 2 arterial punctures occur in supraclavicular approach, whereas in infraclavicular is 4, and 1 pneumothorax are seen in infraclavicular approach, and 2 malposition are occurred in infraclavicular approach. Discussion. In our study, demographic characteristics were comparable in both the groups. Mean duration for supraclavicular approach is 4 minutes, whereas in infraclavicular approach is 5 minutes, which is comparable with the study done by Thakur et al. A successful placement of catheter was 97% in supraclavicular, whereas in infraclavicular is 88%. This is consistent with the study done by Duran et al. 88% were successfully catheterized in first attempt in supraclavicular approach, whereas in infraclavicular approach is 51%. This is comparable with the study done by Hussain et al. Complications in terms of arterial puncture were seen in 2 patients in group S and 4 patients in group I, and pneumothorax was seen in 1 patient in an infraclavicular group, and malposition in terms of cannula tip seen in contralateral subclavian vein was seen in 2 patients in infraclavicular group. This is comparable with the study done by Ajay et al. And Hussain et al. Conclusion, supraclavicular approach is better than infraclavicular approach in terms of number of attempts, less mean time required, successful cannulation, and also complications. And it will be useful during emergency situations, and also can be performed in centers where ultrasound machine is not available. Limitations, fracture of clavicle, infection of puncture site, short neck, deranged coagulation profile are some of the limitations for study in both the approaches. These are my references. Thank you.
Dr. Divya, you are there?
Myself is Dr. Sumita, ma'am.
Oh, sorry, Dr. Sumita. Yeah.
Good morning, ma'am.
So what was your primary outcome? You have mentioned 3 things as your primary outcome. So what was your sample size based on?
Ma'am, actually my sample size is totally 70, which is taken by getting an access time, ma'am. By that we have calculated total 70, which is divided into 35 by closed envelope method, ma'am.
How much access time difference did you expect to calculate the sample size? Like you would have assumed that this procedure will take this much and this much. So what is the reference for that?
Thakur et al. Was done the same study, ma'am, and they showed the differences was 1.5 minutes between the 2 procedures.
Do you realize that a difference of 1.5 minutes will matter in the clinical procedure? Even if your study is also showing 4.5 and 5.8. So do you really think that this difference of some 1 minute, 25 seconds will matter? Is it clinically relevant?
No, ma'am, but compared to access time, we are getting better with the supraclavicular than the infraclavicular, ma'am.
This is access time only, isn't it?
Yes, ma'am.
So that is what I'm asking. A difference of 1 minute, 25 seconds or so, is it going to be clinically relevant?
No, ma'am, not much, ma'am.
You have shown the p-values. You have only seen the p-values, and the p-value is less than this, so it is significant. So, we can't play with numbers in the clinical setting. I don't agree that a difference of 1.5 minutes is clinically relevant, and this is a significant result.
Okay.
With that, did you standardize the experience of the performer who was performing the procedure?
Actually, ma'am, infraclav, ma'am.
You yourself did it, or somebody else who is experienced enough? Did you standardize it? The person who has performed these many
No,
procedures?
ma'am, everything is I only did, ma'am. Initially, supraclavicular was not practiced in an institution. After learning, I only did all the cases, ma'am. Both infra and supraclavicular.
So you only did it. So after how many of that did you standardize? After, for example, in when we are doing it, so for example, in video laryngoscopy, like we say that after doing 50 laryngoscopies, only the person will do. Do you standardize it? After how many you will do?
After around 10 cases over, I well versed with the supraclavicular, ma'am. So infraclavicular usually practiced in our institution, so there's no matter in that. But in supraclavicular, we started with our cases. So after I well versed with that procedures like 10 cases, I only did everything, ma'am.
Like Dr. Neeru also said that I also think that it is not clinically it is not very significant. The time of 1 minute, I really don't think it is that significant.
Okay.
Thank you.
Thank you, ma'am.
Okay, thank you. We can go on to the next presentation.
And this was the last presentation.
Okay. Where are we supposed to submit? Do you have any performer, any idea, or do we ask the organizer separately?
How are we supposed to mark? Yeah, that's why I wanted to ask.
I have marked on presentation and question answers, but I'm not sure how to submit. I'll call you, Dr. I took your number from the WhatsApp group. I'll call you and we'll discuss.
Sure.
So we end this session here. Thank you everyone for participating.
Thank you.
Dr. Shanti, are you there? Dr. Shanti. Dr. Naveen, are you there? Dr. Shanti, are you there?
Good morning, everyone. I'm Dr. Ritam, and my paper discussion is responsiveness of state and response entropy and algorithmicity during intravenous fentanyl administration in male and female patients. Pain is often the most frequent complaint in clinical practice, and gender plays an important role in perception of the pain. Entropy is EEG-based monitor and consists of two components: state entropy and response entropy. State entropy reflects hypnosis component. Response entropy reflects algorithmicity is the quantification of the sensation of pain. Objective assessment of the pain sensitivity is performed by use of the study is to assess the gender difference in response to fentanyl or response to the institutional ethics committee approval, and the study site is named. This was calculated using statistical software. Sample calculation was done based on the study conducted by Vasily. And in the above study, the post-bolus difference in response entropy between male and female while awake was used a difference of 2% in the entropy value with an alpha error of 0.05 and power of 90%. We need to enroll 126 patients in total into two groups of 62, each one male and another female. Inclusion criteria are ASA 1 and ASA grade 1 and 2 patients, 18 to 60 years of age, and exclusion criteria are patient refusal ASA 3, ASA grade 3 or 4, disease or injury affecting the CNS, psychoactive medication, alcohol or drug abuse, allergy to the test medication, renal or hepatic disease, compromised cardiorespiratory function, pregnant patients, psychiatric disorder, patients undergoing intracranial surgery, and well from the institutional ethics committee. The study was carried out over a period of 6 months on the patients aged grade 1 and 2, aged 18 to 60 years, half of them being males and half of them being females. Standard ASA guidelines are followed, and FPX 50 algorithm of Bagley instruments were used in a study to identify pain threshold and pain tolerance. The standard protocol recommended by the manufacturer was followed by calibrating the algometer. The algometer reading at which the subject complex pain is called pain. Data were corrected, tablet corrected for correctness and consistency. Statistical analysis was carried out using SPSS 22 and R environment and Microsoft Word and Excel have been used to generate graphs and tablets. Descriptive and inferential statistical analysis have been carried out in the present. This is assessed at 5% level of. Coming to the results, state entropy on comparison between on comparison with student teachers. The response entropy there are, in this case also there is no not to be found any statistically significant. Algorithm in comparison between student ages between the groups, it is found to be statistic. The results of this prospective observational study showed that there is no statistical results of prospective observational study showed there is no statistical difference in entropy values between male and females after fentanyl administration. In our study, we did not find any statistical significant difference in response entropy and state entropy values between male and female during fentanyl administration. The results of this prospective observational study showed that there was no statistical difference. Coming to the limitations, our study mainly focused on changes in entropy in awake state, and we could not find significant gender differences after fentanyl administration, but we did not evaluate the changes in the intraoperative period. Further studies are required in domain to establish scientific. Coming to the conclusion, we conclude that the fentanyl administration has not influenced the entropy values based on gender and female. Gender and females had a initial low pain threshold and a greater increase in pain threshold after fentanyl administration. Thank you.
Good morning, everyone. My presentation topic is myself. I, Dr. Abhishek Bhaskar. My presentation topic is a prospective observational study comparing the effect of epidural analgesia with intravenous analgesia in blunt trauma chest patient managed by the non-invasive ventilation. अभी Introduction. Trauma remains a major public health problem worldwide as it is associated with a high rate of the morbidity and mortality in both developed and developing countries, encompassing approximately 5.8 million deaths. Thoracic trauma accounts for the 20 to 25% of all traumas worldwide and is the third leading cause of the death in polytrauma patient after abdominal injury and head trauma. Methods. Study setting. The study was conducted in critical care unit department of anesthesiology, King George Medical University, Lucknow. Study 1 year prospective observational study. Sample size is 46, 23 in age group. Ethical clearance by from the KGMU ethical committee. My CTRI number is this. Sample size 46, 23 in age group. Methodology: the present prospective open label randomized controlled trial study was conducted on 46 patients with blunt trauma chest patient divided into group A, the patient who received non-invasive ventilation therapy with epidural analgesia, and group B, the patient who received non-invasive ventilation with intravenous analgesia. Measured VAS score, ICU stay, PF ratio, and hemodynamic stability. Inclusion criteria: the patient giving written with explained written consent will be taken, and patient in the group of 18 to 14, and all blunt trauma chest patient not requiring the surgical management and invasive mechanical ventilation. Exclusion criteria: patient refusal of severe coagulopathy and patient who requires invasive ventilation will be excluded from the study. Observation and result: no significant difference in demographical data were observed between the group, and hemodynamic stability was more in group A as compared to group B, shown below. Mean VAS score much lower in group A as shown in graph and figure, and ICU stay is lower in group A. Mean PF ratio significantly higher in group A. Discussion: my study epidural analgesia in blunt trauma chest patient managed by non-invasive ventilation was score significantly reduced, supported by Weicker et al. Study ICU stay is also significantly lower than the group A, group B, and PF ratio found higher in group A than group B. Hemodynamic stability is more in group A. No limitation and future scope, no confounding factor were taken into the consideration, and future studies were extended in the model of resection of larger group of patients. Conclusive: epidural analgesia is more effective for blunt trauma chest treated with non-invasive ventilation. References this. Thank you. बस हो गया.
Thank you, doctor, for your presentation. You have compared epidural versus intravenous anesthesia. Can you explain why you took this topic? You are comparing totally two different modes of anesthesia, analgesia, right? What is very much established mode, that is now block epidural anesthesia.
IV analgesia received by the patient, sir. And I also, after 72 hours, sir, we remove the epidural.
No, doctor, I want to ask you why you compared epidural and IV analgesia. These are totally different modes of analgesia, and it's very well established that epidural is far better than your intravenous anesthesia, right? Analgesia.
Yes, sir.
So why you took this topic? What is new in this?
Sir, in epidural analgesia, sir, we measure the parameter like ICU study is less as compared to IV analgesia, sir.
I didn't got your point. And second, you didn't again talk about the complications.
Complications within 72 hours, like hypotension, bradycardia, and some at the site of injection coagulopathy. Then in epidural group, we develop
that comes in exclusion criteria.
My exclusion criteria when patient is on ventilator or surgical fixation are not included in our study, and
thank you.
Okay, sir.
So good morning, sir. Good morning, sir. Naveen, sir.
Yeah, ma'am.
Sir, sorry for the delay, sir. I had a problem in getting the connectivity, sir. I'm Dr. Shanti, sir.
Good morning, ma'am.
Good morning, sir.
Hello everyone, my name is Dr. Divya Chauhan and my topic is comparison of ketamine and fentanyl as a co-induction agent with propofol for short surgical procedure. When propofol combined with analgesic agent can provide all component of satisfactory general anesthesia. The combination of propofol with fentanyl and ketamine is recommended for improving the quality of sedation and analgesia and minimize the potential adverse effect of individual drug-related event and maintaining a stable cardiovascular and respiratory status. The aim of study to evaluate the following parameter: onset of induction, hemodynamic stability, recovery time, quality of anesthesia and analgesia, or any adverse effect. Here, patients were randomly allocated into two groups. Each group includes 30 patients. The group propofol ketamine were give injection ketamine 0.5 mg per kg plus injection propofol 2 mg per kg, and propofol fentanyl group give injection fentanyl 1.5 microgram per kg and injection propofol 2 mg per kg. Pulse rate, blood pressure, respiratory rate, SpO2 were monitored and recorded immediately after induction, and then 3 minutes, 5 minutes, 10 minutes, and then every 10 minutes till the end of the surgery. The data obtained from each group were analyzed statistically by unpaired t-test using GraphPad software. As shown in table 1, there was no significant difference in age, sex, weight, and duration of surgery between the two groups. The onset of induction in group propofol fentanyl was significantly prolonged as compared to the group propofol ketamine. The intraoperatively pulse rate decreased in a propofol fentanyl group as compared to the propofol ketamine, but statistically not significant. The intraoperative systolic blood pressure in group propofol fentanyl was significantly decreased compared with group propofol ketamine, and the diastolic pressure in group propofol fentanyl was significantly decreased as compared to the group propofol ketamine. Hypotension, bradycardia, respiratory depression, and pain on injection were seen in group propofol fentanyl, and involuntary movement were seen in group propofol ketamine. The total number of incremental dose and total dose of propofol in group propofol fentanyl were significantly more as compared to the group propofol ketamine. And the recovery time and awakening time in group propofol ketamine were significantly prolonged as compared to the group propofol fentanyl. The propofol is a short-acting intravenous hypotonic and provide rapid onset and complete recovery from anesthesia. It is commonly used during a brief surgical intervention. However, it has not an analgesic effect. Ketamine, a neuroleptic anesthetic agent, provide excellent amnesia without affecting spontaneous respiration, and fentanyl, a potent opioid, provide both analgesia and sedation. Here we conclude that ketamine and propofol combination is better than fentanyl propofol combination in short surgical procedure with respect to hemodynamic stability. However, the recovery was faster with fentanyl propofol combination.
Thank you, doctor. What was the duration of your surgical procedure? Can you hear me? Am I audible?
Yes, sir.
What was the duration of your surgical procedure?
Sir, doctor is not there. Can we move on to next presentation?
Okay, we'll go for next presentation.
Hello everyone, I am presenting a paper of comparative evaluation of intermediate versus propofol on hemodynamic response following endotracheal intubation in adult patients. The increasing importance of the safe anesthesia practice has attenuated the need for anesthetic technique with smooth induction and intubation, stable intraoperative hemodynamic, and rapid recovery with minimal adverse effect. The fluctuation in heart rate and blood pressure, though brief and well tolerated by healthy individuals, may be deleterious in patients with cardiovascular compromise. Choice of induction agent hence should be able to maintain a safe range of hemodynamic parameters, heart rate, systolic blood pressure, and diastolic blood pressure. Recent study was carried out to compare and evaluate the efficacy of propofol and idomidate in preventing hemodynamic response after laryngoscopy and endotracheal intubation in absence to change in heart rate and change in blood pressure. Total 60 patients of the ASA grade 1 and 2 of either sex and age 18 to 16 years posted for elective surgery were included and randomly divided into two groups. Group P includes injection propofol 2 mg per kg IV, and the group E, N is equal to 30, where injection idomidate 0.3 mg per kg IV given. A detailed pre-anesthetic evaluation of all patients were done. The effect of the IV induction agents were observed in relation to hemodynamic changes like heart rate, systolic blood pressure, diastolic blood pressure. After induction, after intubation at 1 minute, 3 minutes, 5 minutes, 10 minutes, 15 minutes, and the 20 minutes of the intubation. The observation of this study were compared with the observation of the other study and between the two groups. Exclusion criteria are those taking the antihypertensive medications, patient with the cardiac, renal, hepatic, and the cerebral diseases, obese, pregnant, and the nursing woman, patient with anticipated difficult intubation, patient with history of suggestive sensitivity to drug used in the study, and the patient not willing to consent. All the continuous variables were recorded as a mean plus minus SD. The data obtained from each group were analyzed statistically by unpaid t-test using GraphPad software. P-value less than 0.05 was considered significant. Result shows demographic data are not significant with each other. Table 2 shows the changes in the heart rate where increase in heart rate after intubation in both the group, but difference was statistically not significant. Table 3 shows changes in the systolic BP where statistically significant decrease in the systolic BP in group B as compared to group E after induction and intubation. Table 4 shows that after induction and intubation, there was a decrease in diastolic BP in group P as compared to group E, which was statistically significant. In our study, we compare hemodynamic responses where after induction, there was a decrease in heart rate in both the group, but there was no significant difference between the two groups. This fall in heart rate could be attributed to the anxiolytic action of fentanyl, which was used for pre-medication. Around 10 minutes and after intubation, blood pressure was becoming normal as compared to pre-induction in group P, whereas in group E, blood pressure remains stable after induction, which shows that etomidate do not have effect on baroreceptor-mediated pressure response. Thus, etomidate provided better hemodynamic stability during induction and intubation. Propofol and etomidate reduces rise in heart rate and arterial blood pressure during the laryngoscopy and intubation, while etomidate shows lesser hypertensive effect. Incidence of pain on injection and bradycardia was significantly higher in group P. Conclusion is single induction dose of propofol etomidate attenuates the hemodynamic response in laryngoscopy and intubation. However, propofol caused significant hypotension while etomidate provided more stable hemodynamic conditions. If there were be no contraindication, it would be preferred over the propofol for general anesthesia, particularly in hemodynamic unstable patients. Thank you.
Doctor, what was your study?
Response on the mostly for the unstable patients.
No, which type of study is this? It was an observational study or it was a randomized clinical trial, control trial?
It's on the observational studies. No?
It was an observational study, right? And what was your primary outcome?
The outcome is etomidate is very helpful for the cardiovascular compromised patients compared to propofol.
Sorry, can you repeat?
For the in endotracheal intubation, the induction agent etomidate is more beneficial.
No, what was your primary outcome at which you calculated your sample size?
Sorry, sir.
What was your research question? What was your primary outcome? How did you calculate your sample size?
From the sorry.
Ma'am, please.
Yes, sir. Doctor, hello. Hello.
Yes, sir. Yes, ma'am.
Apart from this, did you give any other drugs along with etomidate?
Apart from etomidate, no, ma'am.
Then how did you induce?
With the one group induced with the propofol and one group induced with the etomidate.
Okay. Any other drug you gave along with the etomidate and how did you induce? Just tell me.
First, we gave the induction pre-medication. Pre-medication is given and then induction agents is given.
How did you intubate? What drug did you use?
Sorry.
Hello.
Yes, ma'am.
You tell me how did you induce in etomidate group?
Injection etomidate is given.
Yes. You intubated the patient or not? You intubated, no?
Yes, ma'am.
How did you intubate? What drug did you use for intubation? What is the relaxant you use for intubation?
Okay. Muscle relaxant scoring is given.
Okay. Then how many, when did you start monitoring the heart rate?
Ma'am, monitoring is started as a starting from the pre-medication. Pre-medication at the intubation within 1 minute, 3 minutes, 5 minutes, and the 10 minutes.
So what is your inference?
Inference is during the induction and the intubation, there is increase in the heart rate and blood pressure. In group P, in group E, compared heart rate and blood pressure is less increasing than propofol.
Okay, your inference is propofol is better than etomidate.
Etomidate is better than propofol.
Okay.
Not changing the heart rate and blood pressure more than the normal range.
Okay, is there did you observe any side effects with etomidate?
No, ma'am.
Okay, that's all for from me, sir.
We can jump on to the next.
Good evening, everyone. I, Dr. Divyan Mishra, third year PG resident from Pandit Jainam Medical College, Raipur, would like to present a paper on the topic incidence of post-dural puncture headache with 25 gauge quincke and Whittaker spinal needle in cesarean section, a comparative study. Spinal anesthesia is a widespread popular method which is used for a variety of surgical procedures, especially in obstetric field, because of being easy, convenient, and safe for both mother and baby. And since its introduction, PDPH has remained a well-recognized complication and is found to be more common after cesarean section in young patients. Need of the study is incidence of PDPH in cesarean section with 25 gauge quincke versus Whittaker spinal needle has not been studied in our institute before. Our aim was to study the incidence of PDPH between both the needles, and objective was to record the incidence of PDPH, record pain intensity using VAS score, and record associated symptoms like backache, vertigo, nausea, vomiting, etc. Our study was an interventional randomized double-blind study conducted in Department of Obstetrics and Gynecology in patients undergoing cesarean section and was approved by Institutional Scientific and Ethical Committee. We included those patients in whom age was between 18 to 45 years, belongs to ASA class 2 in emergency or elective surgery, and excluded those who refused or a case of PIH or eclampsia, neurological deficit, known case of migraine or any other headache, on any analgesic medication, local site infection, bleeding disorder, obese patients, and more than one attempt taken for subarachnoid block. Our sample size was 232, but we added 10% of total sample size by taking dropouts and exclusion criteria into consideration. So the final sample size was 256. Patients were randomly allocated equally into two groups by using a random number table, in which group Q received subarachnoid block with 25 gauge quincke needle, and while group W received the same with 25 gauge Whittaker needle. All the patients were shifted to OT in the supine position, and multi-para monitor was attached. Baseline vitals were recorded. IV line was secured with 18 gauge cannula, and all the patients were hydrated with 10 ml per kg ringer lactate solution preoperatively and pre-medicated with IV metoclopramide 10 mg. Under all aseptic precautions, subarachnoid block was performed through midline approach at L3 and L4 interspace, and post-operatively all the patients were shifted to PNC ward, and from next day onwards we are inquired about the headache up to 5 days post-operatively. For analysis purpose, only those patients who met inclusion criteria were included. The collected data was put in the master chart in Excel sheet. The results were analyzed by various statistical techniques like number, percentage, mean, standard deviation, student t-test, unpaired t-test, and chi-square test. In terms of demographic profile, the two groups were statistically comparable with respect to age, weight, height, and BMI. 5 patients out of 128, which is roughly 3.9% in group Q and 0% in group W, were complicated with post-dural puncture headache, and the incidence of PDPH in both the groups was statistically comparable with a p-value of 0.0708. Severity of headache was mild in all the reported cases of group Q, and the difference in severity in both the groups was statistically insignificant. We recorded one case of backache in group Q while no associated symptoms were seen in group W, and this difference was also statistically not significant with a p-value of 0.3164. Incidence of PDPH in both the groups was statistically comparable with a p-value of 0.0708. Result of Shutt Ali et al. Was similar to our study, while less incidence of PDPH was seen in the studies of Huang Jie et al. And Rasulias et al. They excluded those patients who required more than one attempt for lumbar puncture as in our study, and this might be the reason for low incidence of PDPH observed by them, whereas high incidence of PDPH was seen in multiple studies such as Shah et al., Shah VR et al., Sohelbi et al., Paul A et al., etc. In most of the studies, authors did not mention total number of lumbar puncture attempts and direction of the bevel with respect to the dural fiber, as multiple lumbar puncture attempts and perpendicular direction of the needle bevel with respect to dural fiber could be the possible causes for high incidence of PDPH. There was also differences in the method of assessment of severity of headache in some studies, which could also account for variation in results. The confounding factors were young parturients and subjective perception of pain. Limitations and future scopes were all the patients were discharged 3 days post C-section, but we did our follow-up for 5 days after discharge. Follow-up was done by a telephonic conversation. So there are high chances that we might have missed the late onset PDPH. We did our follow-up only once a day, so we could have missed the diurnal variation of PDPH. We did not record failure rate of 25 gauge Whittaker needle in our study, as it is non-cutting type needle and required more expertise. Comparison of smaller gauge cutting and non-cutting spinal needles with their failure rate can be studied in future. We concluded that there is no significant difference in the incidence of PDPH between 25 gauge Quincke and Whittaker spinal needle. Since cutting needles are cheaper and easier to insert, they can be safely used for SAB, whereas use of non-cutting needles require more expertise. Here are the references. Thank you very much.
Thank you, doctor. What was the incidence of PDPH in your study?
So the doctor has left the session. Can we move on to the next presentation?
Please do move.
My research paper is on a comparison of a bolus dose of esmolol and lidocaine in reducing blood loss and thus maintaining surgical conditions in functional endoscopic sinus surgery. This was a prospective randomized controlled trial. So bleeding during functional endoscopic sinus surgery can impair visualization and even lead to serious complications like orbital and skull base injury, and therefore making a dry surgical field is a challenge for anesthetists. So in this, a bolus dose of esmolol and lignocaine were given prior to intubation, intraoperative bleeding was quantified, and quality of surgical field was graded. Patients were randomly assigned by computer-generated random numbers into Group E and Group L. Both the groups received standard monitoring. 18-gauge IV line was secured, pre-medication with glycopyrrolate and fentanyl was given. Induction was done with thiopentoid sodium, and patients were paralyzed with atrafusion. So patients that belong to Group E received esmolol 0.5 mg per kg 1.5 minutes prior to intubation. And patients who belong to Group L, which is the lignocaine group, received lignocaine 1.5 mg per kg 3 minutes prior to intubation. So the inclusion criteria included patients coming for elective surgery, functional endoscopic sinus surgery under general anesthesia. Both sexes were included, patients belonging to the ages of 18 to 45, and patients coming under the class of ASAPS 1 and 2 were included. Because esmolol was used, a beta blocker, exclusion criteria included patients with contraindications to beta blockers like bronchial asthma, COPD, and patients with a basal heart rate of less than 60, systolic blood pressure of less than 100 millimeter mercury, patients with heart block, acute decompensated heart failure, patients having a peripheral vascular disease, patients with any other respiratory or cardiac medications, patients with uncontrolled systemic illness, significant organ dysfunction, respiratory compromise were excluded, and patients with known allergies to local anesthetics were excluded. Statistical methods, initial sample size analysis was done using Cochrane's formula, which is n is equal to 4 PQ by D squared, and based on this, a sample size of 25 in each group was obtained. So this was my methodology. Patient selection was done, informed consent and preoperative evaluation was done. Randomization was done by computer-generated random numbers into Group E and Group L. And as mentioned before, Group E received esmolol 0.5 mg per kg, 1.5 minutes prior to intubation, and Group L received lignocaine 1.5 mg per kg, 3 minutes prior to intubation. Procedure was done, monitoring of vitals was done, and assessment of blood loss, both total blood loss as well as average category scale was quantified. Data entry was done, data compilation was done, and statistical analysis. And based on this, the study outcome was obtained. So results using a paired sample t-test, the average category scale between lignocaine and esmolol was compared, and the total blood loss between the two groups were compared. And both showed a significant difference between both groups, as both the groups had a p-value of less than 0.05. So a significant difference was present in both average category scale having a p of 0.007 and total blood loss having a p of 0.004 in lignocaine and esmolol comparison groups. So the average category scale in lignocaine was 2.73 and in esmolol was 2.17, the mean. And the total blood loss in lignocaine was 118 ml.57 and esmolol had a mean of 75 ml. So based on this, I conclude that the blood loss was significantly reduced when a bolus dose of esmolol was given, and thereby quality of surgical field was improved in patients who received esmolol when compared to those who received lignocaine.
Thank you, doctor. We used bolus doses of esmolol and lignocaine.
Dose esmolol and lignocaine, sir.
And our outcome was the overall blood loss, right?
Yes, sir. Both
and the duration of surgery was?
Yes, sir. Sir, I had taken functional endoscopic sinus surgery because it was a short duration, 30 to 45 minutes they would finish.
It was 30 to 45 minutes, right?
45 minutes, yes, sir. Yes, sir.
Was there any significant difference between the duration of surgery?
No, sir. All the surgeries were finished within 45 minutes, sir.
Within 45 minutes. And the duration of esmolol is 10 minutes, right? 8 to 10 minutes.
Yes, sir. But maximum of 30 minutes has been seen. So I had taken it for short procedure.
I got your point, but your short procedure is also lengthening 30 to 45 minutes, right?
Yes, yes, sir.
And whereas you use your these drugs 3 minutes prior to induction, whose duration of maximum duration is about 8 minutes, right?
Yes, sir.
So how you are going to justify that this bolus dose of esmolol lasted for 30 or 45 minutes?
I didn't check whether it lasted for 30 minutes, sir, but I just took the overall.
So you don't have to
loss,
check,
sir.
it's in literature. What is the duration of lignocaine?
Lignocaine is more, sir, 30 minutes to 45 minutes.
We're comparing two drugs with different duration of action, with different mechanisms and same outcome, right?
Yes, sir.
Good, very good. And our primary outcome was total blood loss.
Yes, sir.
Okay, thank you. Ma'am.
Doctor, how did you assess the blood loss? Did you have any rating scale?
Yes, sir. Yes, ma'am. I took average category scale and I also measured the suction apparatus blood loss, ma'am. Average category scale was based on the endoscopic field, ma'am. I only graded it. It was a subjective grading based on the endoscopic field, how much blood loss was there. It was 1 to 6 was graded, ma'am. 1 was no blood loss and thereafter.
But you quantify the blood loss during your conclusion, right?
Yes. Yes, sir.
You
that
didn't
was
put
based
any
on
grades
the.
over there.
No, so both was graded, sir. Esmolol received the average category scale of 2, and the mean blood loss in the suction apparatus was 75 ml, sir. Whereas lignocaine, the average category scale was 3, sir. Most of them had in 3, and the blood loss in the suction apparatus was about 130 ml, sir. So that was what I compared, sir. Average category scale 2 there was bleeding, but frequent suctioning was not required. 3 was bleeding was there and suctioning was required, sir.
So what do you think the basis for doing this study? How did this, how do you think that this will reduce the blood loss? Lignocaine and esmolol with the bolus dose. What is the mechanism behind your study?
Esmolol, because it's a beta blocker, both the heart rate and the blood pressure will be reduced. So therefore, based on the hemodynamics was what the blood loss was reduced because of.
What is the half-life of esmolol and lignocaine?
Esmolol, the peak action is 1 minute. It should, as all 10 minutes, it would.
How do you think it will cause a reduced bleeding in a 45 minutes surgery?
Based on the hemodynamic response only, I compared, but I didn't want to use a more prolonged beta blocker because post-op also there will be reduction in, if I had used metoprolol, that was my basis, ma'am. Because it was a shorter surgery, but as Sir you had mentioned, this lasted for 45 minutes, ma'am. Some of the surgeries lasted for 40 minutes.
Okay, over to you, sir.
Okay, thank you. You would have used, you would have gone for infusion, right?
Yes, sir. I could have tried an infusion, sir.
Okay.
That would have been, yes. Thank you, sir.
Okay, we'll move for the next presentation.
The study was to find out the efficacy of continuous perioperative infusion of the dexmedetomidine for the smooth emergence from the general anesthesia and laparoscopic surgeries. Coughing during the extubation is a critical event as it can lead to the bleeding from the surgical site, laryngospasm, and upper airway obstruction. Procedure of the laparoscopy involves creating artificial pneumoperitoneum, which causes increased plasma level of catecholamines. Elevation of intra-abdominal pressure with the raised diaphragm causes a decreased cardiac output and increase the arterial pressure and systemic pulmonary vascular resistance, leading to hypertension and tachycardia. A drug which can blunt the hemodynamic responses without respiratory depression was required for the same for the smooth extubation. Dexmedetomidine is such a drug which can blunt the hemodynamic responses. In literature, dexmedetomidine has been tried as a bolus dose to blunt these responses, but higher bolus dose associated with the hypotension. Also, not many have tried the continuation of the dexmedetomidine infusion till the extubation to blunt these responses. Hence, in our study, we extended the infusion till the decision to reverse the patient from the neuromuscular blockage to try to see whether this infusion helps in smooth extubation or not. And our aims and objective is to observe the effect of the continuous IV dexmedetomidine infusion on cough and sneezing during the extubation from the general anesthesia. After getting approval from the Institutional Ethics Committee, this randomized control study was conducted in a hospital. This study was also registered under the Clinical Data Registry of India. Patients of both the genders with age group between 8 to 65 years of age, and ASA grade 1, 2, 3 physical status, and patients who are undergone the laparoscopic surgeries under general anesthesia were included in our study. Patients known allergy to dexmedetomidine, obesity, febrile illness, pregnant female, and patients whose heart rate less than 60 per minute were excluded from the surgery. From the study, we have assumed the moderate effect size of 0.6, and with this effect size, we have sample size was increased to 50 per group. All patients were randomly assigned into two groups. Group C received the dexmedetomidine infusion till the definition of the pneumoperitoneum, by the group D received this infusion till the reversal of the neuromuscular blockage. All the patients were given the loading dose of the injection dexmedetomidine prior to surgery, and they were continued as the maintenance dose of the dexmedetomidine infusion. When skin switching was completed, it was defined as the time 0 or baseline of emergence process. From this time to till 15 minutes from the extubation, number of coughing episodes, cough scores, and sneezing were recorded. chi-square test was used to analyze this study. And comparison of the demographics across both the groups were demographics were comparable in both the groups. Coughing were less in the study group, and and shivering was also seen less in the study group compared to the control group. Jones Lee carried out the randomized control study to see the effect of a single dose of dexmedetomidine combined with a low dose of remifentanil infusion on cough suppression. And they concluded that the instead of remifentanil infusion alone, the addition of this single dose of 0.5 microgram per kg during emergence was effective in attenuating the coughing and hemodynamic alterations without respiratory depression. Sneha and Suresh et al. In 2020 carried out the RCT to assess the incidence of coughing after a single dose of dexmedetomidine before the extubation, and they concluded that the infusion of the dexmedetomidine 0.75 microgram per kg prior to extubation didn't affect the severity of the cough. Limitation of the study. We have done our study in surgeries lasting for 2 to 3 hours. Hence, in a prolonged surgery, use of dexmedetomidine infusion might lead to more sedation and or hemodynamic instability. Scope of the study. Its efficacy can also be assessed in other surgeries under the general anesthesia apart from the laparoscopic surgeries. Conclusion. Continuous dexmedetomidine infusion, the reversal of the neuromuscular blockage was effective in suppressing the cough, which was statistically significant, while the shivering was also seen less, but it is not statistically significant. These are our references. Thank you.
So, Doctor, what was your topic?
Sir, good afternoon, sir. My topic is comparative study to find out the efficacy of continuation of the hello, sir. My topic is comparative study to find out the efficacy of continuation of the dexmedetomidine infusion till the reversal of the neuromuscular blockage for smooth emergence from the general anesthesia in laparoscopic surgeries. Smooth emergence in terms of less incidence in cough and shivering.
So your primary outcome was smooth extubation, right?
Yes, sir. In terms of cough and shivering.
In terms of cough and
shivering, sir.
Pardon?
Shivering, sir.
Shivering, cough and shivering.
Yes,
so what
sir.
scale did you use to measure cough and shivering?
Sir, for cough, we have sir, cough grading was it was if grade 1 which was no cough at grade 2, which was a mild coughing, one or two coughs. Moderate cough was defined as a 2 to 5 coughs within lasted for only 2 to 5 seconds, and grade 4 was severe cough lasted for more than 5 seconds.
And for shivering?
And for shivering, we have shivering. There is grade 1 is no shivering. Grade 2 is a mild fasciculations. Grade 2 was shivering affecting.
Okay. What was your primary outcome on which you calculated your sample size?
Sir, cough.
Cough was your primary outcome, and how you calculated your sample size?
Sir, we have assumed the moderate effect size of 0.6, and with this effect size, we required about 45 participants in each group, with allowing type 5% type 1 error and 95% confidence interval. So we with assuming 10% loss to follow-up, we sample size
I'm asking, how did you calculate your sample size? You told your effect size you took as 0.6. Where did this 0.6 came from?
Sir, I didn't get your point.
You calculated as sample size taking cough as your primary outcome, right?
Yes, sir.
So you calculated your sample size taking, you took your this one effect size as 0.6.
Yes, sir.
What is this 0.6? Where this value came from?
Sorry, sir, I didn't get your point, sir.
How you calculate your sample size?
Sir, sample size.
You took some sample size, right?
Yes, sir.
So where did this came from?
Sorry, sir, I'm not getting your point.
Brother, I'm talking straightforward. How you got your sample size, that 40 patients? इट्स इजी इंग्लिश, आपको हिंदी में बताएं आपका सैंपल साइज कहां से आया?
Sir, we have found one research article. Based on that, we have found this sample size.
Okay, ma'am, over to you.
Doctor, did you ask the level of sedation?
Yes, ma'am. We have found the sedation by Richmond agitation sedation scale, and in both the groups, the sedation quality was almost similar. In Group D, in which we have slightly continued the dexmedetomidine infusion till the reversal, the patient remains slightly sedated compared to Group C, our control group, and which was beneficial in suppression of cough, which was our primary outcome.
What scale did you use for grading the sedation?
Ma'am, Richmond agitation sedation scale.
Okay, so in your study group, the patient was more sedated than the control group.
Slightly more sedated. Whether they were awake or following verbal commands or slightly drowsy.
Okay, over to you, sir.
Okay, we'll move on to the next presentation.
Thank you, sir.
Morning everyone. Today's my topic is quantitative effect of positive and expiratory pressure on central venous pressure in closed and open thorax. So why we carried out this study? Well, as we are well versed that the PEEP is helpful in recruitment of lungs and helps in ventilating even normal lungs during intraoperative period as a part of protective ventilation strategy. The baseline and serial values of central venous pressures are routinely used to evaluate cardiac function by knowing the filling pressures of right atrium during cardiac surgery. And in spite of usual clinical practice, the influence of PEEP on CVP among patients with cardiac disease is poorly understood. So what we aim through this study? We wanted to assess the quantitative effect of PEEP on change in CVP in patients with closed thorax before sternotomy as compared to open thorax after median sternotomy when the retractor is maximal in position. We thought that the intrathoracic pressure would become equal to atmospheric pressure in open thorax and CVP would not increase after the application of PEEP. So how we carried out this study? This was a prospective quasi-experimental study started after approval of Institute Research and Ethics Committee and was registered in Clinical Trials Registration of India. Patients of age 18 to 60 years belonging to ASA grade 1 to 3 posted for active cardiac surgeries were included in the study and 62 patients gave consent for the study. Anesthetic management of case was left to discretion of attending cardiac anesthesiologist as per the institute protocol. So study started after the intubation of trachea and application of all hemodynamic monitoring. Fluid infusion was stopped and 3 different levels of PEEP was applied for 3 minutes and corresponding hemodynamic parameters were noted at 1 minute of interval for next 3 minutes. So 3 different levels of PEEP were 0, 5 and 10 centimeter of water. In between 5 and 10 centimeter of water, PEEP was brought down to 0 and kept for 3 minutes. Once the measurements were obtained in closed chest, surgery was allowed to proceed with 0 PEEP. And second set of PEEP intervention was started after median sternotomy just before the aortic cannulation. And similar level of PEEP was applied for 3 minutes and parameters were noted. So what we saw the effect of PEEP on CVP? We noticed the rise of CVP in both closed and open thorax with application of PEEP of 5 and 10 centimeter of water. And the increase in CVP with application of PEEP was statistically significant in both before and after sternotomy. The effect of PEEP on hemodynamic parameters were also noted in open thorax as systolic blood pressure, diastolic blood pressure and mean arterial pressures were progressively decreasing and it was statistically significant, while in closed thorax it remained at the normal level. we observed the direct correlation of change in CVP with application of PEEP, and the magnitude of CVP change was higher in closed thorax. Similarly, it also overestimates the CVP value during application of PEEP in mechanically ventilated patient. And transmission of back pressure applied to the alveoli to the pulmonary trunk and increased intrathoracic pressure play a role in rising the CVP in closed thorax. And in non-cardiac surgery, PEEP was shown to have higher magnitude change in CVP, and heart rate and mean artery pressures were remaining in the normal level, baseline level. We concluded that loss of intrathoracic pressure mitigates the effect of PEEP on CVP partially, and higher PEEP up to 10 centimeter of water can be applied in cardiac patient if required as a part of protective ventilation strategy without any compromise on hemodynamics. These are my references. Thank you.
Thank you, Lalit. What was our surgery?
The study was.
Sorry, sir.
What was our surgery?
Surgery,
In which
sir.
cases we studied these things. These your conclusions.
Yeah, MDR, sir, and mostly elective cardiac surgeries, sir.
These were the elective cardiac surgeries, right?
Yes, sir.
Okay, so through elective cardiac surgeries, you extrapolated your results on intensive care unit patients.
No, sir. This was done in intra-op setting, sir. Before the starting of
Pardon?
This was done before the starting of the case. So first value were taken before sternotomy, and second values were taken after sternotomy before the starting of the surgical procedure, sir.
Okay, fine. So this one, 5 and 10 people applied prior to sternotomy, and then after sternotomy, again we reduced to 0 and we applied 5 and 10.
Yes, sir.
Right?
Yes, sir. Yes, sir. Yes, sir.
So,
yes,
so
sir.
all these readings were taken in same patient.
Yes, sir. Yes, sir. Yes, sir. So all the readings were taken in same patient, and once the procedures was started, fluid infusion was stopped, sir. And during the procedure, during the study, surgical manipulation was also stopped, sir, for like 10 minutes.
Okay, so before sternotomy, you stopped your everything and you measured your PEEP. It's very good. You measured your CVP. After sternotomy, you took your measure with your surgery, right?
Sorry, sir. Last point I couldn't get you, sir.
I mean, you took your you went for sternotomy. You took your CVP values for a cross section of time, and then you stopped your study.
Yes, sir. Yes, sir. Yes, sir.
The studies are stopped within minutes of
yes, sir. Yes, sir. Yes. Yes, sir. Yes. Yes.
Okay, fine. Ma'am, over to you.
Yes, sir. Doctor, you said that the patients were posted for MBR.
Yes, sir. Yes, ma'am. Yes, ma'am.
So it is a valvular heart disease.
Yes, ma'am.
So what do you think what was the baseline CVP and what was the effect on CVP in valvular disease?
Ma'am, baseline CVP usually was around 4 to 6, ma'am. 4 to 6 before the intervention, ma'am. And after the intervention, the rise was increase was after the application of 5 PEEP, it was increased by 1.5 to 2 times, ma'am. And after the application of 2 PEEP, 10 PEEP, it was raised by 2.5 to 3 PEEP, ma'am. And in valvular heart disease, we have assessed another one apart from this main objective. We have assessed in the subgroup of TR, ma'am. So if the presence of TR is there, the effect is a bit minimal, ma'am. The effect, the rise is coming a bit minimal. Apart from that, the effect was as usual in other countries.
Over to you, sir.
And we'll jump on to the next presentation.
Good evening to all. My e-paper topic is a study to compare the analgesic efficacy of dexmedetomidine and fentanyl as adjuvants to levobupivacaine in ultrasound-guided supraclavicular brachial plexus block. Introduction. Ultrasound-guided nerve blocks gives better visualization of nerves. It aids in precise drug administration and provides effective nerve block and minimizes the amount of drug needed per block. It reduces complications like injury to vascular structures and pleura. Levobupivacaine is a long-acting local anesthetic. It is a near enantiomer of bupivacaine with less cardiovascular and CNS toxic effects. Opiates like fentanyl can be added as adjuvants, will improve block quality and duration. Dexmedetomidine is an alpha-2 agonist, improves quality of anesthesia by means of fast onset, prolonged duration, with sedative effects. It provides excellent postoperative analgesia when compared to other adjuvants. Our aim is to compare the onset of motor and sensory blockade and duration of postoperative analgesia when adjuvants like dexmedetomidine and fentanyl added with levobupivacaine in supraclavicular brachial plexus block. Methodology: it was a randomized control study which was conducted in 90 patients. Patients are divided into 3 groups. Group A received 20 ml of 0.5% levobupivacaine with 5 ml normal saline. Group B received 20 ml of 0.5% levobupivacaine with 1 mg per kg dexmedetomidine. Group C received 20 ml of 0.5% levobupivacaine with 1 mg per kg fentanyl. Inclusion criteria: age group of 17 to 55 years, ASA 1 and 2 patients, and patients undergoing elective upper limb surgery. Exclusion criteria: patients with significant coagulopathies, patients with a psychiatric disorder, pregnant patients, and history of renal and hepatic dysfunction. Each group supraclavicular block was performed using ultrasound guided following routine aseptic precautions. Parameters like onset of sensory blockade, onset of motor blockade, and duration of postoperative analgesia was observed. End of injection was considered as time 0. Patients were evaluated for onset time of sensory and motor blockade every 5, 10, 15, 30, and 60 minutes intraoperatively, and postoperatively 3, 6, 12 hourly. Onset of sensory blockade: attaining score of 2 was considered as onset of sensory blockade. Attaining score of 3 was considered as complete sensory blockade. Onset of motor blockade was assessed using 4-point scale. Normal power score 1, weakness but able to move arm score 2, not able to move arm but able to move fingers score 3. Complete motor blockade was considered as score 4. Patients were also assessed for duration of analgesia and time of postoperative analgesia. Statistical analysis was done using SPSS trial version 20. P-value of less than 0.05 was taken as significant. This graph shows onset of sensory blockade and motor blockade was earlier in levobupivacaine and dexmedetomidine group. This graph shows duration of analgesia was prolonged in levobupivacaine plus dexmedetomidine group. Onset time of sensory blockade: in our study, we observed that onset time of sensory blockade was earlier in levobupivacaine plus dexmedetomidine group with mean value of 4.7 minutes. And onset time of motor blockade was also earlier in levobupivacaine plus dexmedetomidine group with mean value of 7.4 minutes. Duration of analgesia was also prolonged in levobupivacaine plus dexmedetomidine group with mean value of 569 minutes. Cannon et al. Have evaluated the effect of levobupivacaine and levobupivacaine plus dexmedetomidine, in which onset of sensory blockade and onset of motor blockade was earlier in levobupivacaine plus dexmedetomidine group. Duration of analgesia was also prolonged in this group. Agarwal et al. Have evaluated the effect of bupivacaine and bupivacaine plus dexmedetomidine, in which onset of sensory blockade, onset of motor blockade was earlier in bupivacaine plus dexmedetomidine, and duration of analgesia was also prolonged in this group. Conclusion: when adjuvants added with a local anesthetic, it improved speed of onset and duration of sensory and motor blockade. In our study, we concluded that addition of dexmedetomidine to levobupivacaine in supraclavicular block shortens the onset time of sensory and motor blockade and prolongs the duration of analgesia when compared to levobupivacaine plus fentanyl and levobupivacaine plus NS group. These are my references. Thank you.
Good afternoon, sir.
Thank you, doctor. What were your primary outcome?
My primary outcome is the onset of sensory and motor blockade was earlier in levobupivacaine plus dexmedetomidine group when compared to levobupivacaine plus fentanyl and plain levobupivacaine group, sir.
Onset of?
Sensory and motor blockade was earlier in
sensory and motor
levobupivacaine.
blockade. You took onset of sensory and motor blockade as your primary outcome, right?
Yes, sir. And duration of analgesia is also assessed.
Duration of analgesia was also your primary outcome.
Yes,
and you calculated your sample size on?
By keeping confidence interval of 95%.
On which parameter?
Sorry, sir.
Duration or onset or both?
Onset. For onset of sensory and motor blockade. For onset.
Sample size on onset of sensory as well as motor.
Yes, sir.
Okay, fine. Yes, ma'am. Over to you, ma'am.
What was the quality of block in fentanyl group?
The quality of blockade is also, when compared to dexmedetomidine, it was little bit later, and onset of blockade is somewhat earlier in compared to plain levobupivacaine group, ma'am.
Okay.
Onset of onset of sensory blockade is earlier in levobupivacaine plus dexmedetomidine group, ma'am, which is around 4 minutes. And in leobupivacaine plus fentanyl group, which is around 5.2 minutes. And plain leobupivacaine group, the onset is around 7 minutes, ma'am.
Okay. Over to you, sir.
What was the method you used to check the onset of sensory and motor blockade?
A sensory blockade were assessed using abolition of pinprick sensation in middle index finger and little finger and dorsum aspect of thumb, sir. Abolition of normal sensation is considered as score 1. Abolition of pinprick sensation is considered as score 2. And abolition of touch sensation is considered as score 3, sir.
Okay, and for motor?
And for motor, using 4-point scale, no motor blockade is considered as score 1. Able to move arm, but if there is weakness is present, it is considered as score 1. Ability to move arm and forearm is considered as score 2, sir. Inability to move arm and forearm is considered as score 4, sir. Onset of motor blockade is score 2, is considered as onset of motor blockade, sir.
Thank you. We'll move on to the next.
Thank you, sir. Thank you, ma'am.
Welcome everyone. I myself Dr. Nitisha Roy. My topic for paper presentation is comparison of pre-medication with midazolam and dexmedetomidine on sedation and anxiety in controlled hypertensive patient undergoing elective surgery under general anesthesia. My guide is Dr. Alka Gupta. Ideal agent for pre-medication should be faster in onset with minimal respiratory depression, minimal cardiovascular effect. Controlled hypertensive patient can also exhibit increase in BP, so it is necessary to pre-medicate the patient with ideal pre-medication. Midazolam is a short-acting imidazobenzodiazepine and dexmedetomidine is a selective alpha-2 adrenergic receptor agonist. Our aim is to compare midazolam and dexmedetomidine as pre-medication for sedation and allaying preoperative anxiety. Primary objective is to study the effect of midazolam and dexmedetomidine in preoperative sedation and allaying anxiety in controlled hypertensive patients undergoing elective surgery under GA. Secondary objective is to evaluate and compare the hemodynamic changes between two groups. Lacuna is only few studies have been conducted in controlled hypertensive patients. Our study is a double-blind, randomized comparative study conducted in the Department of Anesthesiology in ABVMs from 1st November 2019 to 31st March 2021. Cohen's effect size was used to calculate the sample size. Sample size taken was 100, 50 per each group. Controlled hypertensive patients of age between 20 to 75 years were included, and patients with the renal, hepatic dysfunction, uncontrolled hypertensive, patients of beta blockers were excluded. After obtaining written informed consent 30 minutes prior to the induction, Group 1 received 0.02 mg per kg midazolam IV over 10 minutes, and Group 2 received dexmedetomidine 1 mg per kg in 100 ml over 10 minutes. Following parameters were noted in every 5 minutes: Ramsey sedation score, VAS-A, respiratory rate, heart rate, systolic and diastolic BP, and saturation. Midazolam group and dexmedetomidine group were comparable with respect to age, gender, BMI, and comorbidities. Wilcoxon-Mann-Whitney test was used to compare two groups. Two groups were having significant changes in Ramsey sedation score, and no significant difference was seen in VAS-A. A significant decrease in heart rate was observed in dexmedetomidine, and other parameters were comparable like respiratory rate, mean artery pressure, and saturation. Dexmedetomidine group were better sedated compared to midazolam group, which were similar to the study by Uren et al. It was found that both were equally effective in producing anxiolysis, which was similar to the study by Sadit et al. A significant decrease in heart rate was observed in dexmedetomidine group, but was within acceptable range. We conclude that dexmedetomidine is better and safer and more suitable alternative for sedation and attenuating preoperative anxiety with better control of hemodynamics. These are my references. Thank you.
Thank you, doctor. What are the method of randomization and allocation?
Hello, sir.
Hello.
Hello.
Am I audible?
Yes, sir. Can you please? Hello.
Can you tell me the method of randomization and allocation?
Sir, I have used rand between method, and group when it is like group 1 have received midazolam and group 2 have received dexmedetomidine. Rand between have been used.
Pardon?
Rand between.
Can you just explain me?
Yes, sir. Computerized randomization technique have been used, and we will just randomize rand between. We have to click, then we'll get either 1 or either 2. If it is 1,
what are the method of allocation? Group allocation?
Sir, we will give when we receive, if it is 1, we'll give midazolam to the group 1, and if it is dexmedetomidine, we'll give group 2 will receive dexmedetomidine at the dose of.
That is okay, but I think the anesthesiologist which is dealing with pre-medication is unaware of the groups, right?
Yes, sir.
Or did you did blinding?
Sir, actually
there was no blinding.
Blinding was there, sir.
Then how come he knows?
Sir, that infusion will be either will be having dexmed or midazolam, and I'll start the infusion accordingly.
Okay, ma'am, over to you.
Doctor? Hello?
Yes, ma'am.
How did you come to the conclusion that 0.02 milligram per kg was the dose given by you is equivalent to your dexmed dose? How did you come to the conclusion?
Ma'am, according to my parent article study, there was comparison of this 0.02 mg per kg of midazolam as well as this dexmedetomidine 1 mics per kg.
Okay. What is the normal dose of midazolam for pre-medication?
Ma'am, it is 0.02 to 0.1 mg per kg.
You have given 0.02. Is it?
It's a less.
Is it?
No, ma'am. It is actually it's a lesser in terms of pre-medication.
Then
lesser
how?
dose.
Then how can you compare?
It was.
Did you get my question, doctor?
Yes, ma'am. Yes, ma'am.
You are saying how can it then compare? Deliberately, you are giving a less dose.
Ma'am, actually, I have just compared with the from the parent article. There was 3 doses. So, in order to decrease the side effects as well as respiratory depression will be more in case of higher dose. So that's why I have used lower dose.
Okay, doctor. Over to you, sir.
Thank you. Thank you, ma'am. You went for the loading dose, right? In dexmed group.
Yes, sir. Yes, sir.
And what was your loading dose?
Sir, 1 mics per kg per minute. 1 mics per kg over 10 minutes.
1 mics per kg over 10 minutes, right?
Yes,
so
sir.
you have given 100 mics to the patient?
No, sir. 1 mics per kg over 10 minutes. If it is 60 kg, 60 mics over 10 minutes.
Okay, fine. Thank you.
Okay. Thank you.
We'll move to the next one.
Good evening, everyone. My name is Dr. Niyati, third-year resident in anesthesia department in GMS Sola, Ahmedabad. My topic for e-paper is comparison of dexmedetomidine with promethazine and petazocine in tympanoplasty surgeries under mortal anesthesia care, a prospective randomized double-blind study. Introduction: the tympanoplasty involves a reconstruction of the peripheral tympanic membrane with or without conseculoplasty. It is usually done under local anesthesia with sedation under mortal anesthesia care or general anesthesia. According to the American Society of Anesthesiology, a MAC is a planned procedure during which the patient undergoes local anesthesia together with sedation and analgesia. The 3 fundamental elements of the purposes of the conscious conscious sedation during the MAC are the safe sedation, control of anxiety, and pain control. Dexmedetomidine is a selective alpha receptor agonist with properties of analgesia, sympatholysis, and the titrating sedation without major respiratory depression. It reduces the opioid requirements and discharge response to surgery, ensuring a stable hemodynamic state. Dexmedetomidine is increasingly being used as a sedative for MAC for various surgical procedures. Conventionally, the tympanoplastic pentazocine and promethazine were given for pre-medication. Pentazocine is a benzomorphin derivative that possesses opioid agonist as well as weak antagonic action. High doses may cause high blood pressure and tachycardia. Promethazine is a neuroleptic drug which causes tardive dyskinesia, drowsiness, fatigue, respiratory depression in patients with severely compromised respiratory function and constipation. The present study compares the dexmedetomidine with the combination of the pentazocine and promethazine in patient undergoing tympanoplasty under local anesthesia with primary endpoint being the hemodynamic stability, sedation, and microscopic field of vision. Aims and objectives are to assess the effectiveness of the dexmedetomidine with the conscious sedation, to assess the hemodynamic stability, and to maintain the cooperative state of patient intraoperatively after the dexmedetomidine patient undergoing tympanoplasty under local anesthesia. Methods: it is a prospective randomized double-blind study conducted in the Russia Care Center, Ahmedabad. Total 60 patients after getting ethical clearance from the ethical committee of this institute. Inclusion criteria: patient age 19 to 60 years, AS grade 1 and 2, and weight 40 to 80 kg. Exclusion criteria: patient below 90 or above 60 years of age, history of underlying cardiovascular disease or hypertension, or taking any medications. Patient with known sensitivity, local anesthetic drug, lignocaine and dexmedetomidine, pregnant or lactating females. Maternal methods are 60 patients were randomly selected in the two equal groups, 30 patient group with dexmedetomidine and 30 patient group with pentazocine and promethazine. On arrival of the operation theatre, after confirming the adequate need per hour status, patient's heart rate, blood pressure, oxygen saturation were recorded. IV access was secured at 20 gauge cannula and nickel active solution 2 ml per kg was started. Oxygen was administered via nasal cannula at 2 liter per minute. Both groups were given injection calcium at 0.2 mg IV and injection on a center of 4 mg IV was given pre-medication. In group A, injection dexmedetomidine loading was given 1 microgram per kg for over 10 minutes. After that, the maintenance infusion of 0.5 microgram per kg per hour was given. Injection in group B, injection pentazocine 0.5 mg per kg and injection promethazine 0.5 mg per kg IV were given. After the patient's vitals, pulse, blood pressure, SpO and abscess sedation score were recorded at 1, 5, 10, 15, 30, 45, 60, 75, 90, 120, and 150 minutes. After the adequate sedation, ENT surgeon administered local anesthesia in 4 quadrants of the extraordinary canal surgery was commenced after the adequate analgesia. Adverse effects like bradycardia, hypertension, bradypnea, desaturation, nausea, vomiting were noted and treated accordingly. At the end of the procedure, surgeon was asked to microscopic field of vision after during the intraoperatively. At the end of the procedure, patient was shifted to recovery room and were monitored for hemodynamic parameters and effective any. Observation result: the demographic profile shows there is no significant difference. In intraoperative Ramsey sedation score suggested there was there's no difference before the induction, but there is a high statistical difference after the loading dose of dexmedetomidine given. In the pulse rate, there was also high statistical difference after the loading dose of dexmedetomidine remains throughout the procedure. In mean arterial pressure, there was a high significant difference in the giving the loaded dose of dexmedetomidine, which remains throughout the procedure. Conclusion: dexmedetomidine provides adequate sedation and better hemodynamic stability in analgesia without any adverse effect during the tympanoplasty with local anesthesia.
Morning, everyone. Today's my topic is quantitative.
Thank you, doctor. What was your hypothesis?
Hello.
Hello.
Yes,
Am
sir.
I audible?
Yes, sir. Yes, sir.
What was your hypothesis?
So my hypothesis was to compare the analgesic effect, sedative effect, and less respiratory depression effect on the by the dexmed as compared with the pentazocine and promethazine in the monitored anesthesia care for the local anesthetic surgery like tympanoplasty.
Oh, good. This is your objective. What was your hypothesis?
So my hypothesis was to the primary objective was to give the better analgesic analgesia. Second, to for the surgeon for the microscopic field of vision and patient's comfort, and also the surgeon and patient satisfaction during the procedure.
Again, you didn't got it. You started your research with some hypothesis right in your mind.
Yes, sir.
So what was that?
Yes,
what do you thought?
Okay. So Sir, for monitor anesthesia care, the three things are generally looked for, which is analgesia, sedation. So in my hypothesis, I was giving the patient for the same between the two drugs.
Okay, you calculated your sample size on?
Sir, randomized or T test, sir.
Pardon? You took some sample size, right?
Yes, sir, 60.
How many patients
Total.
you took?
Sir, 60 patients are.
60 patients.
Yes,
Where
sir.
this 60 came from?
Sir, T test, sir.
Oh, pardon, didn't got you. Okay, thank you. Ma'am, over to you.
Yes, sir. Yes, sir. Doctor?
Yes, ma'am. Good afternoon.
You have used infusion in one group of patients and
Yes.
bolus dose in another group of patients, right?
Yes, ma'am.
Then you continued infusion of dexam until the end of surgery.
No,
right?
ma'am. Yes, ma'am.
Okay.
And I stopped it 5 to 10 minutes before the surgery.
Okay. Now you tell me what is the onset, peak, and duration of action of pentazocine and promethazine.
Sir, ma'am, the onset of action for promethazine and pentazocine is between 5 to 10 minutes, and the duration of action is about 45 to 50 minutes.
When is the peak?
Peak is at 15 to 20 minutes, ma'am.
What about promethazine? What about promethazine?
Promethazine, the peak action of promethazine is about 30 to 40 minutes, and yes, it lasts for about 60 minutes.
60 minutes.
Yes, ma'am.
What was the duration of surgery?
Duration, ma'am, since it is a tympanoplasty, it may take about 1.5 hours.
So you have given a bolus drugs which will last for maximum of 1 hour. Whereas you have continued infusion in another group, which will be there for 1.5 hours surgery also.
Yes.
How can you compare these two, doctor?
Ma'am, the main reason for the starting of bolus and this infusion is to maintain the sedation throughout the surgery period, and also the analgesia. As the promethazine and pentazocine are opioids, they give analgesia and sedation as well. Whereas the dexmed, by giving the infusion doses, it also gives sedation and analgesia.
Okay, doctor. Over to you, sir.
Thank you, ma'am. We'll go for next presentation.
Thank you.
Hello everyone, I am Dr. Akshirati from KGMU Lucknow, and I'll be presenting my e-paper on the topic the relationship between pre-operative and post-operative C-reactive protein, neutrophil to lymphocyte ratio and platelet to lymphocyte ratio with post-operative pain after total hip and knee arthroplasty. Anesthetic techniques and post-operative pain management are very important for the total joint arthroplasty patients. Metabolic, endocrine and inflammatory response due to uncontrolled pain can increase morbidity and mortality. Inadequate analgesia blocks rehabilitation and aggressive physiotherapy, which is critical to sustain the range of joint motion, as well as it increase the risk of thromboembolism and duration of hospital stay. Surgical trauma causes acute phase response, which allows tissue injury to control and limits infection and initiates the healing process. During the inflammatory response, changes occurs on the lymphocyte level in the blood. Notably, NLR, PLR, and CRP are new, simple, and cost-effective predictors for the prognosis. And the aims and objective of my study are to study the relationship between pre and post-operative C-reactive protein, neutrophil to lymphocyte ratio, and platelet to lymphocyte ratio with post-operative pain after total hip and total knee arthroplasty. The study was registered with CTRI, and after getting from the clearance from was conducted, and the study was conducted in Department of Anesthesiology with collaboration with Department of Orthopedics, and it is a prospective observational study, and it was done for 1 year. And the sample size was minimum number of patients were 105 as per the formula, and the inclusion criteria was the patient who were giving consent of ASA grade 1 to 3 and who were aged 18 to 90 years, and all patients who remained admitted until the stitches were removed. And the exclusion criteria was who were not giving consent and who had some complications and who underwent emergency procedures. Methodology, the recorded data will be demographic characteristics, pre-existing comorbidity, number of blood transfusions, operating time, post-operative analgesia given, duration of hospital stay, and was scoring system pain scoring. And the all patients would receive the same prophylactic antibiotics. Patient will be given intrathecal 15 mg hyperbaric bupivacaine via 25 gauge atraumatic spinal needle from L3 to L4 space in sitting position. Perioperative, periarticular or intra-articular injections will not be applied. The surgical team, technique, and post-operative care will be standardized and kept uniform. The patients will be mobilized, and a standardized rehabilitation protocol will be initiated after day 1 of surgery. Venous blood samples of all patients will be pre-operative 24 hours before surgery, and post-operative day 3 and day 5. Rescue analgesia will be given in the form of intravenous paracetamol and tramadol. VAS course on day 3 and day of mobilization, duration of hospital stay will be recorded, and p-value less than 0.05 was considered to be significant, and there was significant statistical significant ratios were to be observed on the with pain on day 3, and there were also significant statistical ratios which were observed on day 5, and there was a significant correlation between NLR ratios on day 3 and day 5 with the pain VAS scores, and also there were significant outcomes on the basis of the patients who were who had pain were mobilized later and were stayed in hospital for long with high NLR ratios on day 3 and day 5. So the neutrophil to lymphocyte ratio is a simple and easy accessible indicator of general information. Anesthetic can make decisions about the amount, time, and type of analgesia to be used on pre-operative and post-operative NLR readings, especially in the group of patients who cannot convey that they are suffering from pain, in which in long term hampers the mobilization and hospital stay, leading to various complications. To provide maximum post-operative pain control and to facilitate early rehabilitation in THR and TCAR patient, a simple test to diagnose and treat pain. Thus, the current study sought to determine the relationship between NLR and levels and the intensity of pain in patients following total hip and knee arthroplasty.
Thank you, Doctor. Doctor, we have used NLR ratio to provide post-op analgesia, right?
Yes, sir.
So what was that ratio, cutoff values?
So the normal values for the NLR ratios are 0.38 to 3.53, but in our patients, like it was raised. It was between the range of 3.53 to 5. And it is observed that the patients who have already like CVA diseases or the history of who has history of CAD or CVA or dementia, no, they can have prior higher ratios. And
yeah,
also
that's what I mean. These patients who are coming for arthroplasty, they are chronic patients with chronic pain, right?
Yes,
so
sir.
They must be having this NLR ratio on higher side. So how you decided that this ratio? How you decided pre-operative and post-operative?
Sir, like other parameters also, like comparing the CRP and all, they could also be like these patients are chronically, as you have said, that these patients
yes,
are
CRP will be also on higher side for these patients.
That will be also a false rating because they'll be already taking NSAIDs and anti-inflammatory drugs, so these can be on the lower side. But to be compared with the pain, so that was the reading we were getting, that a trend of higher NLR as compared to the PLR and CRP ratios were observed in such.
What I mean, doctor, is that these patients will generally have this higher NLR ratio, right?
Yes, sir.
So this is biased?
To some extent, sir. But all the patients were of osteoarthritis and arthritis, so all will have a higher ratio. So with the normal range, the baseline values were also the same for the comparatively same for the all.
And you went for visual analog scale too, right?
Yes, sir.
So which is a more subjective again?
Yes, sir.
Okay, thank you. Over to you, ma'am.
Doctor, I agree with sir. So this is a non-specific test, should I say? And NLR ratio is based on the surgical trauma, right?
Yes, response to the surgical stressor.
Yeah, degree of surgical trauma. So can it be titrated to the effect of analgesics?
Yes, ma'am. It can be titrated. Like if there is no pain, there will be no. If there is less inflammation, less pain, then these ratios and this will be less in those patients.
See, we already have a non-invasive pain scale. What is the need for an invasive? Daily you have to draw blood, no?
No, ma'am. I have compared it on the day 0 with day 3 and day 5 compared.
Anyway.
Yes,
you
ma'am.
Daily you have to see the NLR ratio.
Yes, ma'am.
When non-invasive scales are available where you can titrate your analgesics, what is the need for this NLR ratio?
We were comparing so that we can in that we can use the scale. You can use this parameter in those patients, in those geriatric patients for them communication is difficult, who has Alzheimer's and who went in post-operative complications, who have something, who cannot convey pain. So for them we can use the scale.
But this will it be altered by other factors in the
Yes,
post-operative period?
Yes,
Definitely.
Yes,
Yes.
DVT and infection and all.
Yes, it is biased. Thank you. Over to you.
What was the mode of anesthesia used in these patients?
So spinal anesthesia.
They were done under neuraxial block, right?
Neuraxial block.
So we can make conclusion that under neural anesthesia there is complete neuroendocrine suppression to noxious stimulus, right?
Yes, sir, as compared to general anesthesia.
So what we are getting is not the response of surgery.
Yes, sir. Not complete.
Okay, thank you. Thank you. We'll go for next.
My title is Comparison of opioid-free versus opioid-based general anesthesia on post-operative pain intensity for laparoscopic surgeries. Background is intraoperative administration of opioid is considered a keystone of anesthesia as well as hypnotics and relaxants. Perioperative use is associated with nausea and vomiting, hyperalgesia, chronic post-operative pain, respiratory depression. Efficacious multimodal analgesia and anesthesia are basis for successful fast-track surgery. Based on the same principle of opioid sparing, opioid-free anesthesia has been introduced, which is a multimodal anesthesia associated with hypnotics, NMD antagonists, local anesthetics, and alpha-agonists. Hypothesis is that opioid-free anesthesia using dexmedetomidine and ketamine is equally effective in providing balanced intraoperative anesthesia and post-operative analgesia with minimal incidence of opioid-related side effects. AIM is comparing opioid-free anesthesia using dexmedetomidine and ketamine with opioid-based anesthesia using fentanyl. Primary objective is calculation of post-operative pain intensity by using VAS score and usage of rescue analytics. Inclusion criteria is patients with AC physical status 1 and 2 aged between 20 to 60 years. Exclusion criteria is pregnant women are the following exclusion criteria. Sample size is was calculated as 28 considering dropouts. Considering dropouts, sample size was calculated to 70, 35 in each group. Group DK and Group F, two groups. Patients belonging to Group DK will receive dexmedetomidine 1 mg per kg diluted to 100 ml NS and injection ketamine 25 mg diluted to 2 ml. Patients belonging to F group will receive 100 ml of NS 10 to 15 minutes before induction and injection fentanyl 1 mg per kg. All patients were induced with propofol and vicronium and then intubated and maintained on 0.5% isoflurane. Any increase in BP and heart rate were managed with increasing isoflurane to 1%. Any fall in BP was managed with injection metformin 6 mg. Any fall in heart rate was managed with 0.6 mg. All patients were received injection dexamethasone, injection ondansetron, injection paracetamol, and injection diclofenac IV intraoperatively. At the end of the surgery, after the surgery, patients were extubated and shifted to post anesthetic care unit and was monitored by using VAS score immediately post-operative and second hourly for 6 hours, every 6 hourly for 24 hours. In post-operative, nausea and vomiting was also noted immediately post-operative, second hourly for 6 hours and 6 hourly for 24 hours. Results are calculated by using standard statistical methods. The results are there was a significant difference in the usage of injection diclofenac at the second hourly between two groups. In group DK, majority of the patient doesn't require post-operative analgesics or they required only one dose. In fentanyl group, majority of the patients will require one dose or two doses. there was a significant difference in VAS score between group 2 at baseline, second hourly, 18th hourly, and 24th hourly. There was a significant difference in the number of doses of ondansetron between two groups. Remifentanil is the most extensively studied drug for opioid-induced hyperalgesia. Experimental studies proved that NMDA receptor agonists such as ketamine inhibit central sensitization and prevent opioid-induced hyperalgesia. Dexmedetomidine, being a selective alpha agonist, is sympatholytic and also has better intraoperative hemodynamic stability. This is due to decrease in central stimulation of parasympathetic outflow and inhibition of sympathetic outflow from the brainstem. Conclusion is that opioid-free anesthesia with dexmedetomidine and ketamine may be an ideal choice for laparoscopic surgeries because of better intraoperative hemodynamic stability and low incidence of PONV and better postoperative analgesia. Thank you.
So we have compared non-opioid with opioids, right?
Yes, sir.
So what was our endpoint?
Endpoint is dexmedetomidine has better postoperative analgesia, sir, and better hemodynamic stability when compared with fentanyl.
We have used VAS score to compare them, right?
Yes, sir.
VAS score at rest or VAS score when patient was ambulated?
VAS score at rest, sir. At
So
rest,
we took
sir.
just VAS score at rest.
Yes, sir.
And what was the rescue analgesia?
Diclofenac, sir, postoperatively.
Diclofenac. And when it was given?
Sir, actually, patient was assessed at immediate postoperative and second hourly and fourth hourly, sixth hourly. Whenever patient is complaining of VAS score of more than 4, that time, sir.
And what was the routine postoperative analgesia given to this patient?
Sorry, sir.
We need some analgesia in postoperative period.
Yes, sir. Postoperative also we used diclofenac only, sir.
Diclofenac was given as a rescue analgesic, right?
Yes, yes, sir.
What was the analgesia given in postoperative period? Some analgesic must be given, na? Or no,
Sir,
we didn't give anything. We
actually,
just gave analgesic as and when required with the patient.
Yes, sir.
We gave a diclofenac only when patient requested for it, right?
Whenever
That means when
patient
VAS score was more than 4.
patient has
And at that
Yes,
at that point of we terminated the study. Whenever patient asked for the rescue analgesia, our study was stopped.
Yes, sir. But we continued up to 24 hours. Sir.
So we continue up to 44 hours and we calculated the dose of rescue analgesic, right? The analgesia was given only when asked by the patient.
Yes, sir.
Is that so? So
Yes, sir.
what came here is the patients with dexmedetomidine never asked for the analgesia.
Sir, not all patients, sir. Out of 35 patients, 16 patients, they didn't require any postoperative
Analgesia for
rescue analgesia.
24 hours.
Yes, sir.
I don't
Only
think so. Okay, ma'am, over to you. I think ma'am is not there. I think ma'am is not available with us now.
Am I audible?
Yeah, ma'am.
Yes, yes, ma'am.
Doctor? Hello.
Yes, ma'am.
Actually, what was the average duration of surgery in your case? Study?
Ma'am, average duration 70 minutes, ma'am. 70 to 75 minutes.
70 to 75 minutes. Did you repeat fentanyl in any of the cases?
No, ma'am. We didn't repeat, ma'am. Starting during induction dose, 1 mg per kg body weight. After that, no, ma'am.
What is the normal dose of fentanyl? 1 mg per kg, is it enough? And duration of surgery 70 minutes. You didn't
Normal
repeat
dose.
any fentanyl. You have not repeated fentanyl.
No, ma'am.
So what is the duration of action of fentanyl?
Ma'am, around 15 minutes, ma'am.
You want to repeat or you don't want to repeat? Suppose if the procedure exceeds 1 hour also.
If surgery is exceeding more than 1.5 hour, we didn't consider, ma'am, that surgery.
Okay, doctor. Over to you, sir.
Thank you, ma'am. We'll jump to next presentation.
Good morning, all. As quoted in Miller's anesthesia, postoperative pain management is the first and foremost challenge for any patient and concern for the same. And in this modern era of eras, it is as challenging as it has become ever. As a student of regional anesthesia from Ruby Hall Clinic, Pune, I would like to present my study on ultrasound-guided single-shot quadratus lumborum block for postoperative pain control in patients undergoing laparoscopic abdominal surgery. It is a randomized, prospective, comparative study between the posterior and transmuscular approach for the stem. As we know that ultrasonography has revolutionized the use of blocks, and quadratus lumborum block has been shown to provide adequate postoperative analgesia after abdominal surgeries. Quadratus lumborum block is an interfacial plane block and its management has been revolutionized with USG, but there is no consensus over which approach is better, or the analgesic efficacy has not been compared in laparoscopic abdominal surgeries. To the best of my knowledge, current study is first RCT defined to compare the analgesic efficacy between both the approaches. It was a randomized prospective comparative study conducted in my college with ethical committee and CTRI been taken, and it was a 1-year study. The primary objective was to determine the duration of the block, which was defined as a time interval between end of local anesthetic injection and patient complaint with VAS score of more than 3. It also analyzed the side effects and dent on VAS score and whether there was decreased requirement of additional analgesics. Parameters were compared: the demographic data, duration, VAS score, side effects, and decreased requirement of rescue analgesics was noted. This RCT was defined to compare duration of analgesia provided by QL2 versus QL3, and we hypothesized that QL3 might be better than the QL2 because of its more vertebral spread of the drug noted. 50 patients were enrolled in the study. 42 were included in the analysis. All were comparable in age, sex, and ASA grading, and all were undergoing laparoscopic surgery. Patients were explained about the technique, the effects, side effects, and written consent was taken. Drugs were used: ropivacaine, lignocaine with adrenaline, and normal saline. 20 cc each and 25 cc was given on both each side. In my first group, type 2, patient in supine position after completion of surgery, linear transducer was placed in the mid-axillary line, and the drug was deposited in the deep layer of middle layer of TLF, and the drug spread was noted in real-time USG. For the QL3 type of block, lateral position was given to the patient, spine was scanned, and drug was deposited between QL and psoas major muscle, and drug spread was noted in the real-time USG. Occurrence of postoperative nausea, vomiting, hypotension, hematoma were noted. VAS score was taken care at 0, 1, 2, 4, 6, 12, 36, and 48 hours. No statistical difference was noted except for the 24-hour QL3 study, which showed a significant lower VAS score in the group. As a part of multimodal analgesia, QL is here to stay with overall reduced in opioids in post-op period with minimal side effects. However, the limitations in my study where it was dependent on USG and a large population study for confirmatory result was needed here. Thank you very much.
Thank you, Doctor. We have used this QL block for post-operative analgesia.
Good morning, sir. Am I audible, sir?
We are using this. Hello.
Yes, sir.
We are using the SQL block for post-operative analgesia.
Yes, sir.
Not for surgery, right?
No, sir, not for surgery.
Okay. Then why we went for 0.75% ropivacaine in this potency?
Sir, that 0.75% was taken only 20 cc and it was diluted up to 60 cc. So effectively it comes around 0.3 or less.
Okay, so 0.3% was used.
Yeah, so 0.75% of 20 cc diluted to 60 cc. It is a standard regimen we follow so that there is no, mishaps occur or unnecessary somebody gives extra dose to the patient. So this is the standard protocol we follow. Lignocaine adrenaline 2% 20 cc, ropivacaine 0.75% 20 cc and 20 cc NS. Because this is an interfacial plain block which needs large volume rather than large concentration.
So I got your point. The second question is why we used two different local anesthetic for this block.
Sir, interfacial plain block itself is a block where I want that the patient should get immediate benefit with xyloadrenaline will give earlier onset, and with ropivacaine will give a more sustained.
What we are using here is this is for post-operative analgesia, right? We are not using for surgery.
Yes, sir.
So we are not in hurried.
Yes, sir. Another
Why
thing
we are giving two
we can avoid the side effects of giving a large concentration of a single drug, whereas we know that when we add two local anesthetics, the synergistic effect will be more beneficial in this patient.
I got your point, but again, the point is same. Why we need that potency? We are giving for post-op analgesia, right? We are not giving for surgery. So we can go for lower concentrations with large volume. We have even gone for 1.25% of ropivacaine, right?
Yes, sir. So this is a interfacial plain block which takes its time to onset, and I want that that effect should start with earlier initiation of the lignoadrenaline, and later on it could be continued with the effect of ropivacaine, because interfacial plain block.
I got your point, doctor. What my point, what I want to make here is we are not going for surgery, any emergency surgery. We have plenty of time. We are planning for post-operative analgesia. Yet we are exposing patient to two local anesthetics, right? Which means we are adding their side effects also.
Yes, sir. So
my point was that.
Yes.
So we would have gone for one drug also.
Yes, sir.
Single drug.
Yes, sir.
So, was there any add-on benefit for adding this second drug, other than this the potency or the faster onset?
For faster onset, for lowering the toxic dose, we can use a very safer dose and not going to the complication. It's being a very relatively new block. We don't want to have any side effects per se. Even if we don't get the benefit, that is okay. But we should not land up any kind of side effect by giving higher dose of a single drug because it needs large volume.
That's why I'm asking why. That's what I'm asking. We would have gone for lower concentration, but we can go with single drug. Okay, fine.
Yes.
Over to you, ma'am.
Yes, sir. Doctor, when did you perform the block?
Ma'am, after the completion of surgery and before extubation. Because this is a deep-seated block, mostly the needle has to travel 6 to 8 centimeter inside the patient's body through the muscles. So we always perform when the surgery is completed. So the surgeon, practically the surgeon is happy that we are not troubling him, he is done with his work. And before extubation, so that we also get ample time to do scanning and to give the drug and locate the spread. And it's a large volume, 25 cc it is to be the given. So we can also get an adequate time. Generally, the team is always in a hurry. The moment the tube is in, the surgeon just wants to start the surgery. So we preferred giving it at this point along with the multimodal analgesia. And we prefer after completion of surgery and before extubation.
Don't you think the complication will get complications due to this local anesthesia may get masked?
Ma'am, basically it's an interfacial plain block. It is not like other nerve block where we look for a vascular. There is no vascular anatomy which is targeted here. So yes, every time while giving the drug, we give 2 to 3 cc aliquots, every time re-aspirating, every time rechecking the spread of the drug. However, this being an interfacial plain block, the chances of landing up in last is quite lesser than the blocks where we target a vascular structure and give the block. And the patient under anesthesia will be more cooperative than a patient who is not, because this is a deep seated, that needle has to travel 6 to 8 centimeter inside the body. So we actually find it very easy to give this block when the patient is under anesthesia.
Okay. Okay, doctor. Over to you, sir.
Thank you, ma'am. Doctor, don't you think if you had gone prior to surgery for this block would have been more beneficial for the patient?
Yes, definitely, sir, because then the onset of
After
the
induction
action would have.
after induction of anesthesia,
Yes, sir. Sir,
you can
this.
go for block.
Yes, sir,
This-
definitely. But as I have told you, sir, the surgeon, the moment the tube is inside, he is in a hurry to paint and all, and this being a very new
No,
block.
I agree to you, doctor, but patient, but
Yes, definitely, definitely. I would
after
also
induction
agree.
of anesthesia, if you go for this block, this is more fruitful, I think.
More fruitful, sir. I would have
Thank you.
maybe have required less fentanyl and less intra-op medication.
Right. Intra-op as well as other anesthetic.
Yes, requirement of all those things would have decreased, just like we use sub-anesthetic dose of ketamine for the same purpose. You can cut down.
Thank you.
Thank you so much, sir. Thank you,
We'll
ma'am.
move to the next one.
Hello all, I am Dr. Dinesh, currently working as registrar at Apollo Creed. This is our audit regarding pain relief after cesarean section. Adequate pain relief after cesarean section is important to reduce morbidity, improve the patient experience, and facilitate maternal bonding with the neonate. The provision of adequate analgesia must also be balanced against the maternal adverse effects and the risk of drug transfer to the neonate through breastfeeding. The usual protocol followed in our hospital is like administering diamorphine or morphine or fentanyl in spinal along with bupivacaine, diclofenac suppository at the end of the procedure, post of paracetamol 1 gram QID and ibuprofen 300 milligram TDS of 100 milligram postoperatively, and Oramorph as and when required 10 to 20 milligrams, PCA with morphine. And in patients undergoing general anesthesia, tab block or local infiltration with levobupivacaine are also provided. The aim of our audit is to mainly see the efficiency of the pain relief provided to the patients, whether it is followed being to the protocol with the staff or being informed about it, as well as to see the effectiveness of pain relief observed in patients undergoing cesarean section. The parameters were like we undertook around 80 patients, 40 undergoing elective and 40 patients undergoing emergency cesarean section. And we assessed the following: the patient's knowledge about the pain relief, analgesics given intraoperative and postoperatively, spinal or general anesthesia, and the pain score observed every hour for the first 24 hours. We also had some secondary objectives to monitor the hemodynamics and also document any reason for not giving the usual post-op analgesics. Our observation showed that only 2 patients out of the whole 80 had a complete idea about the pain relief options available to them. 30 patients had some knowledge about the pain relief but weren't too sure about what's being done. And the remaining staggering 48 patients didn't have any idea about any pain relief options that are available to them. Regarding the type of anesthesia provided, 74 patients out of the 80 underwent spinal. The remaining 6 patients, 4 of them were in emergency, so was given general anesthesia, and the remaining 2 patients were for an elective section and they preferred general anesthesia. So with regards to the 74 patients who underwent spinal, from this chart we can see that in case of emergency, out of the 36 patients, only 23 received intrathecal opioids, whereas in case of an elective surgeries, almost most of the patients received intrathecal opioids. When we obtained the VAS score after 6 hours, in patients who underwent for emergency cesarean, 26 of them didn't have a VAS score of less than 2. Sorry, they had a VAS score of less than 2, while 13 patients had a VAS score of 3 or 4, and 1 patient, especially the patient who underwent GA, had a VAS score of 6. Whereas in elective procedures, all the patients, almost most of the patients had a VAS score of only 0 to 2, and 8 patients has a VAS score of 3 or 4 after 6 hours. The other observations is that 12 patients didn't receive any NSAIDs since the blood loss was greater than 1500 ml. None of the patients received PCA for post-op pain relief. They weren't given that as an option. In the patients who underwent general anesthetic, 2 patients received tap block and 2 patients received local infiltration, and the other 2 didn't receive anything. The patient with epidurals who were in labor analgesia proceeding to surgery under epidural, they have been excluded for convenience. To conclude, patients undergoing emergency procedures and under general anesthesia have a higher amount of post-operative pain compared to elective procedures, and patients' knowledge about pain relief is well below the adequate level that's necessary. Staff should ideally be more meeting and educated more about pain monitoring and pain relief options, which they can communicate to the patients as well as doctors. And we aim to improve these things and repeat an audit after 6 months to see how things have progressed. My references, and thank you.
Thank you, doctor. This was the audit of your institute, right?
Sorry, sir. Yeah, it was an audit performed at our institute, sir.
Okay, this was audit from your institute. So you got with some shortcomings which are present at your institute, right?
Yes, sir.
So, right. And what about after this intervention has been done? So you came up with only one report prior to your interventions, right?
Yes, sir. So
this is just a questionnaire you got. What are the shortcomings in your institute?
Yes, sir. So what we have done is half reading. The thing is, so we have just presented about what are all the issues we have found in the audit.
These are all the issues you got up. Now, after implementation, what will be your what quality improvement will be there is yet to come?
Yet to come. So what we have done is now we have started printing out protocols. We are putting it in every ward. The department has started a few classes for the staff and these things. So we have escalated to
this is just an audit report, right?
Audit report, yes, sir.
So this should not be presented anywhere. This is just for your institution, right?
Yes, sir.
After implementation of your this quality things, you can present it, right?
Yes, sir.
So
Okay.
we came up with this questionnaire, then we implemented our things, and then we came up with this result.
Yes, sir. Okay.
So we are not with any results.
Yes, sir. So we'll be planning as well, sir. For that. Okay. Sir.
Ma'am, over to you.
Yes, sir, I completely agree with you, sir. Actually, this is a report which is actually a confidential report of your institution. So it's not a study, so we cannot comment on that. But I have one question. Do you give adjuvant opioid for all C-section as for emergency, or you don't follow?
We give, as per the protocol, all patients undergoing cesarean section, they receive opioids unless they have any side effects or allergies.
Okay.
Final, yeah.
Thank you. Thank you.
Both emergencies and electives, they receive.
Okay. Thank you.
Thank you. We'll proceed for next presentation.
Respected ISACOON-2021 delegates, the paper presentation title is Comparative Study of Epidural Nalbuphine and Tramadol as an Adjuvant to the bupivacaine for Postoperative Pain Management. The postoperative pain relief has come within the realm of an anesthesiologist. Epidural analgesia is one widely used for major surgeries, including lower limb and lower abdominal surgeries. Addition of opiates in combination with local anesthetic agents in low doses offer a new dimension in management of postoperative pain, and one combination ideal yet to be found, and this study is one such attempt. The aims and objectives of the study include the assessment of quality of analgesia to compare the satisfaction score of the drug combination, post-op hemodynamic parameters, and incidence of side effects or level of patient satisfaction. Ethical clearance obtained from the institution and consent was taken from the patient. Following prospective randomized comparative study design was followed. Age of group 18 to 60 patients with ASA grade 1 and 2 undergoing elective lower limb and lower abdominal surgery patients were included. Patients not giving consent, pediatric and geriatric age group patient with spine abnormalities, pregnant females, above knee and below knee amputees, patients with bleeding diastasis on anticoagulant therapy, mentally retarded patient, and patient with systemic disorders were excluded from the study. This was the formula employed for calculation of the sample size, which was rounded off to 30 in each group. Patients underwent elective surgeries under combined spinal epidural anesthesia. Under aseptic precaution, epidural catheter was placed in lumbar L2, L3 space, and followed by LP was done in L3, L4 space with injection bupivacaine 0.5% in subarachnoid space to achieve adequate block. For postoperative analgesia, patients were randomly divided into group N and group P. Both received 0.125% of epidural bupivacaine, either 10 mg nalbuphine in group N or 50 mg tramadol in group P, making up a total volume of 10 ml. Following top-up, these following parameters were recorded, such as hemodynamic parameters, including saturation, heart rate, systolic and diastolic blood pressure immediately and after 5, 10, 15, and 30 minutes, duration for next top-up, quality of analgesia by visual analog scale, post-top-up sedation scale, and need for rescue analgesic, and any adverse effect which is requiring vasopressor and antiemetic therapy. Following analysis method was employed on statistical data. The observation of my study included there were no differences in both group in case of demographic representation, that is age, gender, and ASA distribution. The hemodynamic parameters between the both group, there were no much difference and no significance with respect to heart rate, systolic blood pressure, diastolic blood pressure, and saturation. The visual analog score was significantly lower in that of the group N compared to group P. Sedation score and requirement of antiemetic therapy and rescue analgesic frequency was more in case of group tramadol than the group nalbuphine. The top-up interval time between the group N and group P was found to be highly significant, and it is more in group nalbuphine. Results, the group were similar with respect to that of the age, sex, ASA, heart rate, systolic blood pressure, and diastolic blood pressure, and it was significantly lower in case of visual analog scale and sedation score in case of nalbuphine. Antiemetic therapy and rescue analgesic was significantly lower in group N, and mean time interval top-up was significantly higher in that of the group nalbuphine. So addition of opioids with epidural bupivacaine provides a post-operative pain relief and good analgesia and prolongs the duration of analgesia. And this study compared nalbuphine with that of the tramadol, and the quality and patient satisfaction score and the duration of analgesia was found to be better in nalbuphine group. The satisfaction, was also supported by the study conducted by Veena Charat and Devendra Verma et al. So the conclusion of my study include adding nalbuphine with epidural bupivacaine for postoperative pain management provides better pain management, patient satisfaction, and with less incidence of side effects compared to that of the tramadol. Thank you.
What were the surgeries you took in this study?
Sir, I included patients who were undergoing elective surgeries for lower abdominal surgeries, below umbilical surgeries like total abdominal hysterectomies or vaginal hysterectomy, and even lower limb orthopedic surgeries or any general surgery.
Is epidural justifiable for abdominal hysterectomy?
So, post-op
is
analgesia
epidural
is
justifiable for abdominal hysterectomy?
Hello. Hello.
Is post-operative epidural? Can you hear me?
Yes, sir. Yes, I can, sir.
Is post-operative analgesia, epidural analgesia, is justifiable for abdominal hysterectomy?
So it is one of the better modes of post-operative analgesia.
We don't have to look only at the better modes. We have to look for the pros and cons. We have to look at the risk also. The risk which is carried by the epidural analgesia is much higher than a superficial surgery like abdominal hysterectomy, right? So putting a patient to that risk just for post-operative analgesia is not justifiable.
Okay.
We have more sophisticated means to give post-operative analgesia, right? For such a superficial surgery.
Yes, sir.
Ma'am, over to you.
Dr. Karthik,
yes,
why did you choose tramadol to compare with nalbuphine?
Ma'am, in my institution, the commonly used opioid as an adjuvant was tramadol.
but there were a lot of side effects like nausea, vomiting, and even sedation was more with tramadol. So to find an alternative with lesser side effects, we used nalbuphine.
What about fentanyl? Don't you use it? Fentanyl?
Ma'am, in our setup, there's government setup where fentanyl is not freely available in our institution. So tramadol was freely available and it was commonly used. And fentanyl, there is a scarcity in our institution about fentanyl, so we didn't use fentanyl.
Okay, doctor. Thank you. Over to you, sir.
Thank you. We'll switch on to the next presentation.
Thank you.
Kanchan ma'am, please start your presentation. Dr. Kanchan, please start your presentation.
I think this was the last presentation for this paper presentation. Anybody from organizers is there?
Yes, sir.
So we're done with the presentation, right?
Yes, sir.
Okay. We can end the session, right? Thank you. Thank you, ISACOON. Thank you, ma'am.
Thank you, sir. Thank you. I thank the organizers for giving me this opportunity. Thank you, sir. Thank you all.
नाही नाही वन